Hello, I'm Stuart Montgomery, a Professor Emeritus of Psychiatry at Imperial College in London. It is my very great pleasure to be co-chair of this conference. It is my privilege to welcome you to the 19th IFMAD meeting after 2 years of silence imposed by the epidemic. COVID-19 has caused a pronounced rise in all depressive and anxiety-related disorders. It has also made it much more difficult to meet with and help those who need our assistance in making their recovery. It has emphasized the need for and importance of face-to-face discussion of the facts from careful, evidence-based science in managing serious illness. We look forward to discussing, among many topics, what is new in anxiety, stress disorders, bipolar disorders, and depression, in separating episodic depression from chronic and treatment-resistant depression, the management of inflammation and drug abuse which affect depression. We need to discuss the possible role of genetic predictors in depression. In short, how can we make personalized treatment more personal? I look forward to meeting you during the conference and to catching up with the latest findings and updates in our field, which make it easier to understand the challenges we face. IFMAD has always succeeded in sharing new findings in a friendly, collegiate setting. We now meet in new virtual circumstances. I very much look forward to furthering our knowledge while enjoying the presentations and discussions which have made our past meetings so helpful. I hope you have an interesting and rewarding conference.
Thank you very much, Stuart, for your kind introduction. Dear colleagues, on my behalf of the colleagues, Professor Young, Professor Vieta, my name is Siegfried Kasper. I'm the Professor Emeritus of the Medical University of Vienna, Austria, and I would like to greet all the participants, which are over 150, coming from 40 different countries, most of them 50% from Europe, 25% from Middle East, 5% from Asia, 5% from Canada, most countries coming like Lebanon, UK, Spain, Egypt, Thailand, Korea, Venezuela, South Africa, New Zealand, Austria, just to mention a few of them. So the COVID crisis made it possible for us that we meet in these virtual surroundings, but needless to say, we would look forward to meet all in person, which hopefully will be the place next year when we have the personal meeting in Budapest. Like Stuart, I wish you all the best for the meeting and looking forward discussing interesting topics with you.
Hello, my name is Professor Alan Young, and I am co-chairing the first session, the Rising Stars oral presentation with my friend and colleague from Barcelona, Professor Eduard Vieta. We have two presentations, one about genetic variations with treatment response in bipolar depression from Dr. Anelia from Spain, and there'll be a 5-minute period for questions, which Professor Vieta will chair. And then we will have a Rising Star oral presentation, the role of sex in patients with major depressive disorder, finding from across Europe by Dr. Bartova from Austria, and I will chair that. Without further ado, let's go on to the first Rising Star presentation.
Hi everyone, I'm Gerard Mella, member of the Bipolar and Depressive Disorders Unit in Hospital Clinic in Barcelona. And I'd like to thank you all for this huge opportunity of being here presenting you this work entitled Genetic Variations Associated with Treatment Response in Bipolar Depression. So the background for this work we performed is that in the last decade, several pharmacogenetic decision support tools for medication selection in psychiatric disorders based on genetic variants have been developed. These pharmacogenetic decision support tools are mostly available for major depressive disorder and for schizophrenia. However, the evidence for pharmacogenetics in bipolar disorders is still scarce. So the objectives of our work were to evaluate the impact of individual genes with pharmacogenetic relevance in other psychiatric conditions in patients with bipolar depressions. Our outcomes were in the response to treatment and the presence of adverse drug reactions. We performed an observational retrospective epidemiological study, including participants with bipolar disorder aged more than 18 years old, and we enrolled them and looked for a major depressive episode, which we call the index episode, that was more than 6 months before enrollment. We assessed participants clinically with the CGI modified for bipolar disorder scale, and we assessed them at 3 time points: at enrollment, at the beginning of the index depressive episode, and at the end of the index depressive episode. We also collected sociodemographic and clinical data, the pharmacological treatment that they were using at the index episode, and if adverse drug reactions were present during the index depressive episode. These participants at enrollment, they provided a saliva sample, and we performed a pharmacogenetic test, which is called Neuropharmagen. This test is provided by AB Biotics, which is a company, and the test provides analyzes all several genetic variations for psychotropic drugs and provides clinicians with a color coding system. We can see an example of this color coding system in here, in which we have white color, green color, amber color, and red color for each of the treatments, of the psychotropic treatments that are analyzed. For example, treatments that are white here, it means that no genetic variants relevant to the treatment have been found in this pharmacogenetic test. If the treatments are green or are green coded, it means that they have increased likelihood of positive response and lower risk of adverse drug reactions. If the treatments are coded amber, there's a need for drug dose monitoring and less likelihood of positive response. Here we have agomelatine, imipramine, or triptyline, they're all amber. And treatments that are coded red, for example, citalopram, in these patients, they have increased risk of adverse drug reactions. So once we performed this pharmacogenetic test in all the patients included, we saw that patients were using more than 2 and mostly 3 or 4 drugs at the index depressive episode. So it was very difficult to assign them a concordant or discordant drug regimen with the pharmacogenetic test. What we had to do here is analyze for individual drugs. So we assigned each participant for each drug, whether they were genetic variant carriers, wild-type genotype, or they were not using this drug treatment. And the analysis was performed on individual drugs. Statistical analysis performed were multiple regression, linear regression analysis with a forward selection approach for the identification of pharmacogenetic and clinical predictor variables with a significant contribution to clinical response and adverse drug reactions. So a total of 76 patients with bipolar disorder were included, most of them female and most of them with bipolar disorder type 1. the mean of adverse drug reactions was 0.9 during the index depressive episode, and 20 patients experienced mood switch. Here in this graph, we can see the medications used in the index episode. We can see that most patients were using lithium, second treatment was quetiapine, third anxiolytics, fourth selective serotonin reuptake inhibitors. And here in this graph, we can see the CGI for the modified version of bipolar disorder evaluations at the beginning of the index episode, at the end of the index episode, and at enrollment. Those were the 3 time points of assessment. And here are the pharmacogenetic results. We can see that the pharmacogenetic variable amber color for quetiapine, which is associated with a genetic variant in the cytochrome 3A4, associated with reduced metabolism of quetiapine or increased concentrations in the central nervous system. It was associated with decreased CGI at enrollment. So this variable was associated with an increased therapeutic effect. The green color for risperidone or paliperidone, which is associated with a 4-gene combination in the mTOR pathway, it was associated with decreased adverse drug reactions. So this variable was associated with increased tolerability for risperidone and paliperidone. And finally, the green color for serotonin and norepinephrine reuptake inhibitors, which is associated with the ABCB1 transporter, associated with increased levels of antidepressant in the central nervous system. This variable was associated with decreased CGI and increased adverse drug reactions. So this variable was associated with increased probability of therapeutic effect and decreased tolerability of this antidepressant. As a conclusion of our results, we may say that pharmacogenetic testing shows promising results on treatment effectiveness and tolerability in bipolar disorder. However, our study is retrospective and the sample is of 76 patients, so further research on validity, reliability, clinical usefulness, and cost effectiveness of the pharmacogenetic decision support tools in bipolar disorder is needed before the implementation into clinical practice. And as more evidence becomes available, predictor models which incorporate pharmacogenetic and clinical characteristics may one day help to decode the complexities of treatment response in bipolar disorder, and clinicians may be able to predict patient response to medication. This is a picture of the bipolar and depressive disorders unit, and here is my email. Again, thank you all for this huge opportunity, and I'll be glad to answer your questions.
Thank you. Thank you very much, Gerard, for this very nice summary of what represents and a good example of what precision psychiatry may mean for the future. And I think we are all aware of some of the limitations of such studies, as you mentioned, about sample size and about the need to replicate the findings. But I would like to ask you something. In your results, it looks like the ability of the pharmacogenetic test was a bit better in terms of predicting tolerability rather than predicting efficacy. Do you think that the future of pharmacogenetics is more likely to be focused on tolerability rather than efficacy?
Hi, Dr. Vieta. Thanks a lot for the opportunity of being here again. And regarding your question, it's a complicated, really complicated question to answer, since all the pharmacogenetic tests that are commercially available right now range from a lot of different mutations in different genes and so on. So one of the difficulties that we had is that with the company that we were working in this study, for example, the test changed over the years, so that the results had to the results changed a little bit in considering which mutations were assessed and which mutations were not assessed. So it was very difficult, because in some treatments the assessment was on the CIP 450 metabolism of drugs, or there were some mutations in several genes that were associated with effectiveness or efficacy. So it's complicated. It depends, I think, on the discoveries that are coming and the ones that are going to be implemented into real clinical practice. So I would say I don't know how to answer your question. It depends on a lot of factors. Thank you.
Thank you, thank you. And then my second question for you, before we move to the next presentation, is about the fact that you and Lucia have been selected for this Rising Star session. Do you see yourself, and I hope that Lucy can also answer this question afterwards, but this will be up to Alan. Do you see yourself working in the near future in this area of so-called precision psychiatry? In this case, you are working in the genetics, but I know you're doing other things about innovation. Do you see yourself working in precision psychiatry paradigm?
I don't know if Lucy wants to answer first, Professor Bartova, or
she may answer after her presentation,
okay.
Maybe. Yeah.
Okay. So thanks for the question again, Dr. Vieta. I think it's inevitable that we find ourselves working in precision psychiatry, either fields of psychiatry, because that's what we're trying to do, to characterize better our patients, to find better treatments, to reach prediction, at least based on clinical factors, on genetic factors, etc. So I would say yes to this question. Thank you.
Thank you very much. So I'll handle it to Alan to move to the next presentation. Well, actually, maybe you want to introduce Dr. Bartova, Alan.
Dear Professor Young, dear Professor Vieta, thank you so much for your nice introduction. Dear audience, I wish you a wonderful day, and I would like to let you know that I feel really very honored to have been selected as one of the rising stars of IFMAD 2021. I am really very happy to be here today with you virtually and to have the unique opportunity to introduce the awarded study, the role of sex in patients with major depressive disorder, that represents findings from a cross-sectional European multi-center study. Very shortly to my background, I am senior consultant and researcher at the Department of Psychiatry and Psychotherapy at the Medical University of Vienna in Austria. Currently, I am also absolving a research leave at the University of Bologna in Italy. For the purpose of completeness, I would like to show you my potential disclosures with this slide. And before we will go more into detail, I would like to shortly introduce you the background of our research. The present study was conducted by the European Group for the Study of Resistant Depression, the GSRD. The GSRD represents an international research consortium involving 8 European countries, including Israel, which you could see on this slide, together with some of my highly appreciated colleagues, as Professor Siegfried Kasper, for instance, who is currently coordinating the GSRD research and who is also affiliated with the Medical University of Vienna. Now, the GSRD exists since more than 2 decades. Since 1999, the GSRD has systematically investigated biological and clinical correlates of depression, its treatment, and treatment response patterns, with specific focus on treatment-resistant depression. Our findings which has been evidenced by the GSRD during the last 20 years, were recently summarized in an overview that was published in 2019 in the World Journal of Biological Psychiatry. Should you be interested in our research, we are very happy about exchange. So please free to contact me via email. You can see my email address here below, which will also appear on some of my next slides. The present study, the role of sex in patients with major depressive disorder, is not included in the overview, since it represents very recent results that were accepted for publication this year in depression and anxiety. So what do we know about the role of sex in major depressive disorder now? From existing international evidence, we know about relevant sex-related effects on the evolution and phenotype of depression. One of the most relevant facts is that depression was shown to emerge twice as common in women as in men. Further important aspect is that clinical manifestations, coping with depressive symptoms, and help-seeking patterns were repeatedly shown to differ between female and male patients with depression. And with respect to antidepressant treatment, sex was shown to influence efficacy as well as pharmacokinetics. And what does this mean more in detail? Females with depression was repeatedly associated with the so-called seasonal component, with anxiety, with affective lability, and also with atypical features. And concurrently, the concept of the so-called male depression was increasingly introduced and was characterized by agitation, by increased impulsivity, irritability, risk-taking behavior, and also comorbid substance misuse, for instance. And generally, these identified sex-related differences in depression were shown to be not universal and to vary across the lifespan and a wide array of nations. They were investigated in both animal models as well as in humans. And hereby, psychological and personality factors, as well as biological underpinnings reflected by different genetic, hormonal, as well as neuronal pathways, for instance, were identified as possible explanations for these sex differences. So to extend and to specify the current understanding of the sex-related effects in major depressive disorder, our goal was to determine the male to female sex ratio in an international and naturalistic sample of 1,410 adult in- and outpatients with depression as primary diagnosis, who importantly underwent adequate psychopharmacotherapy. Subsequently, we explored possible differences in sociodemographic, in clinical, and in treatment patterns between male and female patients with depression. Short summary to our method. The present study represents a secondary analysis that was based on a European multi-center cross-sectional, observational, and non-interventional study using retrospective assessment of treatment response that was conducted between 2011 and 2016 by the GSRD. All included subjects underwent a comprehensive clinical assessment. Hereby, the mini international neuropsychiatric interview was employed in order to establish the primary psychiatric diagnosis, potential presence of psychiatric comorbidities, or specific additional features as melancholia or psychotic symptoms, for instance. To assess the extent of depressive symptoms, we employed the Montgomery and Asperg Depression Rating Scale, as well as the 21-item Hamilton Rating Scale for Depression. And statistically, we conducted analysis of covariance, chi-square test, and logistic regression analysis. And what did we find out? In the total sample of 1,410 patients with depression, we identified 467 males and 943 females. From the clinical perspective, our male patients with depression were associated with inpatient treatment settings, with moderate to high suicidality levels, with higher mean daily doses of the administered first-line antidepressant agents, and higher proportion of prescriptions with noradrenergic and specific serotonergic antidepressants. We also observed a trend towards a more frequent administration of combination and augmentation treatment strategies in men, especially antidepressant combinations and augmentations with mood stabilizers. And what about females? Our female patients with depression were related to outpatient treatment settings, to lower suicidality levels, and to the presence of somatic comorbidities, which were thyroid dysfunction, migraine, and asthma. And we also observed a trend towards earlier age of onset of depression in our female patients with depression. So let me conclude for you. These identified divergences may contribute to the concept of the so-called male and female depressive syndromes, and may also serve as predictors of disease severity in course, as they reflect phenomena that were previously repeatedly related to the so-called treatment-resistant depression. Especially the greater necessity of inpatient treatment and the more complex psychopharmacotherapy that were employed in men may reflect the increased therapeutic efforts that might have been undertaken to treat suicidality or to avoid treatment resistance. Hence, considering sex may support the diagnostic and treatment processes towards targeting challenging clinical manifestations as suicidality and comorbidities, for instance, and prevention of treatment resistance and chronicity. And now I'm at the end of my presentation, and the only thing left for me to say is thank you very much for your attention. And in this context, I would also like to say thank you to my highly appreciated colleagues involved in the GSRD research for the valuable support and unique collaboration. Thank you very much.
So, thank you very much, Dr. Bartova. I'm not sure if we're back live yet, but I think we might be. Can you hear me, Dr. Bartova?
Yes, I hear you perfectly.
Well, thank you for a very nice presentation. So a couple of questions, one which is biological and one which is more psychosocial. So the biological one is, did you examine women's reproductive health with relation to depression, particularly the menstrual cycle and whether they were postmenopausal or premenopausal?
Thank you very much for pointing out this relevant aspect. All our patients, also female patients, represented the majority of our sample, were adult. The mean age was about 50, and the mean age of onset was 37. So the patients were, the female patients were partly in reproductive age, but not all of them. We did not detect any significant influence of age.
Okay, so it wasn't, so you weren't able to examine reproductive factors directly, because with the menstrual cycle, which I've had an interest in over the years, if you take a cross-sectional assessment in the follicular phase, that's very different very often from the luteal phase. So that may be a thing to examine in future studies, I guess. And if the mean age was 50, then you will have some who were postmenopausal, and you know, even early menopause, not unusually happens at early 50s, late 40s. The other question is psychosocial. So were there differences in psychosocial factors between men and women that might explain your findings, particularly employment, educational levels, and so on and so forth?
We actually did not detect any significant differences, but we detect differences which did not survive the correction for multiple comparisons. For example, we detected differences in terms of marital status. So our male patients were more commonly in an ongoing relationship as compared to females. This was the only finding which was significant but did not survive the correction.
Oh, I see. So, I mean, my understanding of the literature very broadly is that being in a relationship with a woman is helpful for the man, but not necessarily helpful for the woman. So that might explain some of the differences. Well, thank you very much to both of our rising stars. I'll ask my colleague, Professor Vieta, to join me. I'd like to thank both of you for very interesting presentations, which really live up to the label of being rising stars about the pharmacogenetics and also the sex differences. And I'll perhaps hand over to Professor Vieta to close the session. Edward, would you like to close?
Thank you, Alan. Yes, I'm very pleased with this session. To be honest, I think this is a very nice initiative that Leonetta Baldini, who is one of the key persons for IFMAD, actually put forward and advised to the committee. I think the committee was right to put this session at the forefront of the meeting. And we've been very pleased with both presentations, which were very good, very well adjusted to the time available. So I think it's the greatest start I could think of for IFMAD. And I think this time we can move to the next session. And I think we are going to enjoy very much, even though in this virtual form, this amazing meeting that is IFMAD. Thank you.
Thank you.
Good afternoon, dear colleagues. I am back on stage and I'm delighted to chair this session together with Professor Palanti from the University of Firenze. Stefano, buongiorno.
Good afternoon.
And we have a wonderful program dealing with an update of anxiety disorder, psychobiotics for stress disorder, and then finally functional outcome of bipolar disorders by eminent speakers. The first one will be Professor not Professor Palanti, it's Professor Bandelot from Germany, and then also Professor Dianan from UK, and then Professor Alan Young from UK again. So I have the pleasure to introduce the first speaker, is Professor Borbin Bandelot, Professor Emeritus from the University of Göttingen, and one of the experts on anxiety disorders, writing numerous national as well as international guidelines and treatment algorithms on anxiety disorders. And so he is the one who is also a practicing psychiatrist, but on the other hand, also a psychotherapist. So he knows all different angles of treating depressed and anxiety patients. And today his talk will be on the treatment of anxiety disorder. Professor Bandelot, if you would take the floor, please.
Yes. Do you see my slides, everybody?
Yes, excellent.
Yes. Okay, so I can go on. So I'm going to talk to you about the treatment of anxiety disorders in update. And first have a short look at my financial disclosure in the left corner. And I also have to mention that not all drugs mentioned in this presentation have a license for anxiety disorders in all countries. So please refer to the local regulations. I see someone talk. I hear someone talking in the back. Maybe he has to switch off his microphone. Okay, I go on. Treatment of anxiety disorders. A couple of years ago, we had made a guideline for the treatment of anxiety disorders, and by the World Federation of Societies for Biological Psychiatry. This was in 2008 and 2012. And according to these guidelines, we see the dark green. These are the drugs that have sufficient evidence and a positive risk-benefit ratio. These include the SSRIs like Sertraline, paroxetine, or venlafaxine and duloxetine, the SNRIs. And also in this guideline, pregabalin was also in the first-line treatment. Today, it has been downgraded in some guidelines because of possible withdrawal reactions. On the side of psychotherapy, CBT was the psychotherapy that had the best evidence. And the next line, in the greenish column, you see quetiapine. This is a drug that has shown good efficacy, but according to the metabolic syndrome, this is not a first-line drug, and it's not licensed in most countries, only in Venezuela and the Philippines for the treatment of anxiety disorders. You know, this is a schizophrenia drug. And then we have the tricyclic antidepressants, which have more side effects in general compared to the SSRIs and SNRIs. And this is why these are second-line treatments for anxiety disorders. Then we have the benzodiazepines. They're also second-line because of possible addiction problems that might occur with these drugs. Problem is that, on the other hand, they are very well tolerated and they have good efficacy, but only second or third line due to these addiction problems. Phenelzine, the MAO inhibitor, is almost not used anymore because of the severe side effects or interactions. Then we have some drugs that have less well proven evidence. These include buspirone. Buspirone was shown to be effective in some placebo-controlled studies, but in others it was not so effective. The same is true for moclobemide. And opipramole is a drug that has been only investigated once in a positive study, but this is not enough for 1A level of recommendation. And hydroxyzine is a drug that is only used in some countries like the US and Germany, Austria, but not many people use this drug. It has some studies, but no long-term studies. We looked for exercise running. That worked also well, but better than placebo, but not as good as clomipramine. Inconsistent evidence was shown for psychodynamic therapy. Most studies show it's worse than CBT, and there are almost no studies showing it's better than doing nothing. Then we have some studies, like herbal preparations have not been tested. There's one exception, the studies on lavender oil published by Siegfried Kasper. And this is the only herbal preparation that has shown efficacy. And autogenic training has not been tested. Then other things have been tested. This is negative evidence. That means beta blockers have been tested in a number of studies and were shown not to be effective. The same is true for these three: biofeedback, hypnosis, and EMDR. Now, these were the first-line treatments. What can you do when nothing works? First, you should switch within the group of the first-line treatments. That means you can switch to another SSRI The SSRIs are chemically different. That means it makes sense to switch between one SSRI and another one, or to an SNRI. Also, you can switch to clomipramine or imipramine. Pregabalin is a very good option also if the others do not work. Or in some severe cases, when you have suicidality or severe cardiac diseases, then you might use benzodiazepines. And finally, moclobemide and buspirone might be an option. Then we have some drugs that have not been licensed for these anxiety disorders, like mirtazapine, but there have been some studies in China, which I cannot read, double-blind studies showing that mirtazapine is effective in GAD. Quetiapine, there are 4 good studies, but according to the FDA and the EMA, these drugs are not licensed here. And quetiapine has good evidence, but the metabolic syndrome. Agomelatine has shown efficacy in a couple of studies. All 4 studies were positive, but it's also not licensed for GAD or other anxiety disorders. Phenelzin is licensed for panic disorder and social anxiety disorder, but severe side effects and interactions. And vilazodone is a drug only licensed in the US, but it has shown efficacy in at least 3 studies showing good efficacy for anxiety disorders. And it's not licensed in the US for anxiety disorders, only for depression. We have 2 new anxiety disorders in the DSM-5. One is separation anxiety disorder. There's only one small trial by Frank Schneier from 2017 showing that vilazodone, the American drug, is effective in the treatment of anxiety disorders. And you can also see improvement in selective mutism with drugs like fluoxetine and sertraline were shown to be effective. And there have been some small studies that psychotherapeutic approaches are better than waitlist controls. A couple of years ago, we made this large meta-analysis of all treatments of anxiety disorders, 234 studies, including about 40,000 patients altogether. And so we used pre to post effect sizes. That means we just looked at the Hamilton scores before the treatment and after. A very simple method, but usually in most meta-analysis, you would compare a drug and a placebo and look only for the difference between placebo and the drug. But with this pre to post effect size method, we can put in many, many more studies. This is one advantage. And also we can compare drugs and psychotherapies, because usually drugs are compared to placebo, which has a high effect size. You can see it here. Pill placebo has an effect size of 1.29, whereas CBT usually is compared to a waitlist, and waitlist has a very low effect size, almost no effect. So it makes a difference if you compare to a pill placebo or to a waitlist. And then we just put these treatments all in a row, and the SNRIs were the winners. So the effect size, Cohen's D, was 2.25 for the SNRIs, and then followed by the benzodiazepines. And also we looked at CBT plus drug. You might wonder why this is not more effective than SSRIs or SNRIs. It's because in these few studies, they use sometimes drugs which are not the best ones, not the highest effect sizes. Also, the SSRIs are good, and all these do not differ significantly. You can see that the confidence intervals overlap. Also, TCIs are a little less effective. Then you see the orange squares. These are psychological therapies. Relaxation was the best one, 1.36. And then we see CBT. Normal CBT is 1.3. And to our surprise, we found that pill placebo has 1.29. So no difference. And these are 100 studies. These are 100 studies. That means this is a very robust finding. And my computer said you need 90,000 more studies to refute this result. CBT in groups is a little less effective, 1.22, and then followed by internet therapies, non-face-to-face therapies, psychodynamic therapy, only few studies and less effective. Then we have the psychological placebo, which is a control group. That means like students are talking to the patients without applying any specific techniques. This is the best control group for psychotherapy. And it showed that CBT, normal CBT, compared to psychological placebo was different. But all the others, like psychodynamic therapy, like relaxation, did not differ from psychological placebo. Every treatment differs from waiting list. This shows that waiting list is not a good control condition. Now we put all the drugs in a row, and this is very surprising that quetiapine, a drug which is not licensed at all for the treatment of anxiety disorders, had the highest effect sizes, 3.39, very high effect size, followed by citalopram. And when you look down in the list, you see buspirone has 1.17. So the best drug is 3 times more effective than buspirone. And also phenazine is not the strongest drug in the world. Fluvoxamine, moclobemide, all these drugs do not show such high effect sizes. And this means there is a real difference which drug you use. In the next slide, I will show you the drugs that are effective for the treatment of anxiety disorders. And I put in agomelatine here. This came later after we published this study. It's 1.78, right in the between. So these are the drugs that are recommended by the guidelines and have high effect sizes in the pre to post meta-analysis. Duloxetine, venlafaxine, escitalopram, and paroxetine, these are drugs that you can use. And then this is good for your patients if you use these drugs. Then we looked at medications versus psychotherapy. We put on all the drugs all together, the good ones and the best ones, and obtained average effect size of 2.02. For psychotherapy, it was only 1.22. In other words, with psychotherapy, you can achieve only 60% of the decline in Hamilton scale scores and whatever. That means it's better for the patient if you take a drug, especially in those affected by the disorder very much. So it might be an advantage of psychotherapies if it had longer duration of effect. We looked at follow-up studies. So these studies started where the treatment ended. Here was treatment end and the beginning of the follow-up period, and we looked up to 2 years later. So we had many, many follow-up studies in between. And we looked at CBT, other psychotherapies. We looked at drugs. We looked at placebo. And what were the results? Here you can see the results for CBT. CBT started here and it got better. That means after 2 years with CBT, you have even an increase of effect. So the patients were even better than here when they stopped CBT. Same was true for medications, for other psychotherapies. Other psychotherapies had the same curve here. What would you expect if you stop a drug? You would expect when stopping the drug here, it goes down like this on the next day when you stop the drug. But this is not what we did see. What we saw is this. Medications also had an enduring effect. And this was not statistical different. And also placebo had the same effects. Less effects, but no differences here. The only difference was between placebo and CBT at the end. But you cannot say that medication has less enduring effects. The thing is that during this period, people doing many things in the follow-up period, they keep on going with CBT, they keep on taking pills, they do whatever they want. So you cannot control what people do in the follow-up period. The most important thing that we learn from this study is that you cannot believe follow-up studies because they are superimposed by many, many other factors. Now, in the COVID times, everybody looked at internet therapy. There are many studies now available, and we also did a meta-analysis on internet therapy. So we put them all in one row. Here you can see ICBT. ICBT is the Internet Cognitive Behavioral Therapy. It was more effective than a psychological placebo, you can see. But it was not different from a pill placebo and was not different from face-to-face CBT, normal, I mean, with personal CBT, no different, but it was less effective than medications. And the difference to face-to-face CBT was only minimal. But it was more effective than psychological placebo and waiting list. So you can use ICBT, but only as an add-on to maybe normal CBT or as an add-on to medications. There are some reasons why the effects in these studies may have been overestimated. The internet interventions were only compared with a wait list. And this is not a good comparison, as I told you. And 97% of the studies were not blinded, and the main efficacy measure was only filled out by the people at the other end, the participants, and they were not blinded to the treatment they were on. 89% of the patients were not recruited from clinical settings, but from newspapers or websites, and 63 had an academic background, meaning they were students or they were doctors or psychiatrists by themselves or whatever. And in only 15%, the diagnoses were made by real psychologists or psychiatrists. And what do you expect when you have contact with the people at the other end, the study investigators? These were not psychologists, these were psychology students without any education. In most studies, when you read the studies closely, you will find this. Also, every third patient was on ongoing medication during the study. What we also found, what is new in anxiety disorders is virtual reality. You can imagine there were times when we went to a hotel in Budapest and sitting in the hotel and everyone was staring at us, and now we just are staring at our own monitor. This is embarrassing for people with social phobia. And then this could be practiced with virtual reality. Also, you can use augmented reality. That means you put a spider in your normal environment, and you see everything normal, but only the spider is virtual. The efficacy compared to in vivo exposures showed inconsistent data. It was not as good in many studies as real exposure, and only in SAD and specific phobia. In this year, we finished the German guidelines for anxiety disorders. It's not surprised that psychological therapies was again number one, psychotherapy and medications like SSRIs and SNRIs. And also we said that internet interventions were only as add-on to CBT or medication, and virtual reality for specific phobia and as add-on in SAD. Now, I come to the end of my presentation. So there are some new anxiolytic drugs, but unfortunately, there's nothing very new right now that we can say that in the next 2 or 3 years, we can use these drugs and we can do better treatment for anxiety disorders. So the targets were serotonin. I told you about vilazodone, which showed some efficacy in clinical studies. Then we have 2 very old drugs, dapiron and tandospirone. Tandospirone is used in Japan and China for many years, in Taiwan, but without having any double-blind studies. And glutamate drugs like ketamine may be an option, like esketamine is working in depression. neuropeptides like oxytocin have been investigated, but so far not with a clear success. Some GABA compounds are under investigation, like zuranolone. Cannabinoids like cannabidiol will be tested in the future for the treatment of anxiety disorders. You know that this is not THC. It doesn't make this high feeling with cannabis. It's one of the promising parts of cannabinoids which might be working. And other drugs like curcumin, which comes from the yellow root curcuma, might be effective, and galphamin B are currently under investigation. So this is my last slide, and the future. Now I'm going to talk about politics, about medications. The health authorities, the FDA and the European EMA have increasingly stricter regulations for new drug applications, leading to increasing development costs. You have seen this in the COVID crisis. So the EMA took many more months to give the new drug application for BioNTech. And the British were almost done with the vaccinations when we started in Germany due to the EMA. And the governments are reluctant to reimburse newer drugs, as the old ones are very inexpensive. Like in Germany, you pay like $100 for treatment with paroxetine or citalopram for 1 year. So, and the 1 hour of psychotherapy is also 100 euro. So there's no difference between 1 hour and a whole year of drug treatment in Germany. And pharmaceutical companies are withdrawing from the market. The last FDA approval for anxiety disorders was duloxetine in 2007. And that means in the next 20 years, it will be very difficult to find any new drugs for anxiety disorders. So we have to take what we have. And with this, I'm going to finish my presentation. Thank you much for your attention.
Thank you very much, Professor Bandelot. That was, again, a very excellent presentation, as you always did during the previous IFMAD meetings. And I would like to encourage also the participants to send in questions. If you go to the virtual portal, then you can go to the question part, and please send something in that we can answer these questions. And before we have these questions coming in, which unfortunately are not there anymore, I myself and Professor Pallanti will give you a few questions. You mentioned zuranolone. Do you think that because the biological background of this compound, that it should affect the extrasynaptically GABA receptors and therefore not having a potential for abuse? Do you see any role for this new medication which have approval right now for postpartum depression, for instance, that they could have also a role for anxiety disorders?
Yes, we know from the nature that we can calm down without having addiction effects of our biological compounds that we have in our brain when we want to calm down. And so the aim should be that we disentangle these calming effects from addiction effects. So if we had some kind of benzodiazepine without the addiction effect, this would save humankind. Everyone would take this pill without getting addicted. Everyone would have less anxiety and work faster. So my hope is really that if we have a GABA compound that has no addiction and has some the same effects on GABA, because GABA is like a braking fluid in the human brain. It breaks if it's a brake, if you push a brake, and then a GABAergic compound is a brake assistant, so you can stop excitement or arousal even faster. So
thank you very much. Mm-hmm. There is one question coming in from the floor, and again, I encourage the colleagues also to send in. So the question is a very relevant one. So you mentioned that there will be no new medication for anxiety disorders in the future, but what is the role of the patients' association, since anxiety disorder is very frequent, considering this situation do the patient association advocate for changes in the system?
Well, this is very difficult. I mean, patient advocations could go to the governments and tell them, please send us money so we can do studies. But usually studies are performed by the pharmaceutical companies. And if you cannot promise the pharmaceutical companies that they could earn any money with the drug later, when they have developed a drug, then the pharmaceutical companies won't do that. And even I have my doubts that any government organization would give so much money so we could develop new drugs.
Along this line, would you also agree that when the governments, I think they're all pretty much the same in Europe, in Austria, Germany, UK, so that we have a two-class medicine soon, that the richer ones, they just buy this medication and the poorer ones don't get this medication. Is this a trend towards two-class medicine?
No, I think so, because now many drugs come from China and India and they are very inexpensive. So at the moment, we don't have any expensive drug. So there are some countries, like I think in Mexico, where they still pay like $5 for one pill, which is worth only 20 cents in Germany. So there you find something like two-class medicine, but maybe when we have new drugs, they must be much better than the ones that we have, because the ones that we have are already quite good. And to be much better, you cannot sell a drug for $5 when it has to fight against others that cost only 20 cents.
Right. So, Professor Palanti, would you have also a question for Professor Pandelo?
Yeah, I feel that the question about the new research and new discovery in the field of anxiety treatment is very relevant. What's about, that my patient about neurostimulation? Do you think that there is room for any of this new approach? I mean, neuromodulation, non-invasive neuromodulation for anxiety?
Yes, at the moment, I think there are not so many controlled studies. This might be an option for the future, especially the non-invasive methods like RTMS might be an option. They also, when you look at obsessive compulsive disorders, I'm currently working on the World Federation new guideline, and I found that many studies have been performed with obsessive compulsive disorder. There it might be a very good option, but at the moment I cannot recommend it as a routine method.
So thank you very much. With the thought on time, I think we covered all these topics very sharply, and it's my great pleasure to give the word to the co-chair, Professor Palanti, who will introduce the next speaker. Stefano, please.
Thank you, Siegfried. It's my pleasure to be here today. Thank you, Siegfried, as organizer, Stuart, all the other friends. And it is my privilege today now to introduce Professor Ted Neilan. Ted Neilan is very well known as a principal investigator at PC Microbiome Ireland and emeritus professor of psychiatry, University College. He previously was chair of the clinical neuroscience and professor of psychological medicine at San Bartolomeo Hospital, London. And also, he has been working on both continent, UK and US, and he worked in the research laboratory, got a PhD in pharmacology at the University of London, and fellow of the Royal College of Physicians and Psychiatrists, as well of the American College of Physicians. And he was one of the first to start the study of a good microbiota in stress-related disorders, and also he worked extensively on the regulation of the hypothalamic pituitary adrenal axis. He was for that in 1995 was awarded for the Melvin Ramsey Prize for research into biology of stress, and SPSK ranked as #1 global expert on microbiota, and also is listed in the top 100 global makers and mavericks. His age index is impressive, 120, and his current research is funded by the Science Foundation Ireland, the Health Research Board, and European Union. Published more than 500 papers, books on pharmacology, and is in the board of several journals. So we we crave to listen his presentation today. We are very pleased to introduce him. So I let the room to Professor Diner. Thank you, Kenya.
Great.
Okay.
Thank you very much indeed for that introduction. It's a great pleasure to be with you this afternoon. What I would like to do is look at the way in which gut microbes influence stress responses and the way in which we might be able to target the gut microbiota in managing stress-related disorders. Now, these are just some of my, I suppose, conflicts of interest. My funding has largely come from Science Foundation Ireland, but from some other sources as well. So if we look at the gut microbiota in the average adult, it consists of about 1.5 kilos of bacteria, which is about the same weight as the human brain, but it contains an enormous amount of genetic material. And I always make the point that, you know, we've obviously grown up in a symbiotic relationship with the bacteria in our intestine. But if we were to take all of the genes in the bacteria, the product of which we require, we wouldn't be able to fit all that DNA in our cells. So genes manufacture a lot of products that our brain and other organs in the body require. And in turn, of course, we feed those bacteria. Now, the predominant phyla are Bacteroidetes and Firmicutes, but we have over 1,000 species of bacteria in our intestine. Now, what determines the microbiota that any of us have? Well, the initial determinant is how we were born. A baby born by cesarean section has initially a very different microbiota to a baby born per vaginum, because the baby born per vaginum picks up lactobacilli as it passes through the mom's vagina, whereas the baby born by cesarean section will acquire its initial microbiota from the bacteria on the skin of the mum, the skin of the doctor, and from the general environment. But over the first 2 to 3 years of life, there is a convergence in the microbiota between those babies born by cesarean section and those born per vaginum. So what are the determinants of the gut microbiota in adults? Well, the primary determinants would be our diet. A bad diet full of highly processed foods will lead to a bad microbiota. If we exercise a lot, that will lead to diversity in the gut microbiota as well. Of course, medications impact the gut microbiota, and it's estimated that over 80% of all the medications that are regularly prescribed in Europe or North America have an impact on the gut microbiota, and most of them not a positive impact, I might quickly add. Now, we all want to age healthily, and there is overwhelming evidence to indicate that maintaining diversity in the gut microbiota is essential for healthy aging. If we lose diversity, then frailty follows very rapidly. So there are some of the factors that determine, you know, the gut microbiota in your average adult. Now, I always regard the gut microbiota as a bit like a fecal fermenter. The large intestine, which contains most of the microbes, is like a large fecal fermenter producing hundreds of molecules, and many of these molecules will be required either in the intestine or by other organs in the body. So in many ways, the gut microbiota is like another organ. It's an organ that we've ignored until relatively recently, but it is actually and functions like an organ in its own right, just as, let's say, the liver is an organ in its own right, although the gut microbiota biochemically is actually far more complex than the liver. So how do gut microbes actually communicate with the brain? They communicate with the brain in a variety of ways. The vagus nerve is a bidirectional communication route. And we've shown in our lab that certain microbes can only communicate with the brain when the vagus nerve is intact. If the vagus nerve is severed in an animal, those microbes cannot communicate with the brain. Another important route of communication is the production of short-chain fatty acids. Bacteria can produce short-chain fatty acids like butyrate and propionate. It is known that butyrate is a very potent HDAC inhibitor, so it acts as an epigenetic regulator in the brain. I suppose in terms of drugs that we employ, sodium valproate is a HDAC inhibitor. Well, butyrate is a HDAC inhibitor and an epigenetic modulator. It was until relatively recently thought that all of the tryptophan that reached the brain to produce serotonin came from our diet. That is not the case. Some of the tryptophan is actually manufactured by bacteria. We were the first to show that bifidobacteria could significantly elevate tryptophan levels. So there are a few of the ways, it's not an exclusive list, but there are some of the ways in which gut microbes actually communicate with the brain. Now, I think as a psychiatrist, it is very interesting that all of the key neurotransmitters can be produced by bacteria. Now, I'm not suggesting for a second that these neurotransmitters reach the brain. They clearly do not. And even if they could, they wouldn't cross the blood-brain barrier. But they do impact on the enteric nervous system, which in turn, of course, has an impact on brain function. So, for instance, we've profiled a large number of lactobacilli, and they all, to varying extents, produce GABA. But serotonin, noradrenaline, dopamine, all of these neurotransmitters can be produced by bacteria in the intestine. Now, a few years ago, 4 or 5 years ago, I was interested in answering the question, what is the microbiota like of patients who attend my clinic at an outpatient, a regular outpatient clinic for major depressive illness? So we took a group of patients with major depression and we took a group of age and sex-matched healthy controls. And if you look on the right-hand side of the screen there, you see a principal component analysis showing that the gut microbiota of patients with depression is very different to the gut microbiota of healthy subjects. Essentially, in depression, there is a loss of diversity and richness that you see in the normal healthy scenario. And surprisingly, now it's easy to do a microbiota transplant in a rodent. It's more difficult in humans, but of course it's done as well for treating C. difficile infection. But if you transplant the gut microbiota from a depressed patient into a rodent, and you compare that with a rodent who's had a transplant from a healthy subject, you find fundamental differences. The gut microbiota transplant from a depressed patient leads to depressive type behaviors in a rodent, and at the same time results in alterations in tryptophan metabolism and an increase in inflammatory markers. So the gut microbiota transplant into a rodent from a depressed patient results in biochemical and immune alterations as well as behavioral changes in the rodent. Now, I always make the point because I think it is very important. At this point in biology, in time in relation to biology, we cannot change the genes in ourselves, but we most definitely can change the genes in our microbiota. And we can do this in a number of ways. I've mentioned fecal microbiota transplant a while ago. The only clinical indication for that right now is C. difficile infection. But there are other ways. We can use an alteration in our diet can radically alter the gut microbiota. We can take in prebiotics, which promote the growth of good bacteria, or we can take in probiotics, sometimes referred to as live biotherapeutics. All of these ways are ways in which we can alter the gut microbiota. Now, a few years ago in a paper in Biological Psychiatry, we introduced a concept which is caught on in the literature. A lot of people use the term now, and it's the term psychobiotic. And we define a psychobiotic as a live bacteria which, when ingested in adequate amounts, has a positive mental health benefit. Now, there are lots of probiotic bacteria out there. Most of them do nothing from a mental health perspective, but there are bacteria out there which several groups, including our own, have shown can impact behavior in animals or mental health in humans. And the Psychobiotics Revolution is a book that I was associated with my colleagues, John Crine and Scott Anderson. Now, this is a probiotic study with a biflongum 1714, and essentially it's a placebo-controlled study where the subjects received either a probiotic, which is biflongum 1714, or placebo, and then they switched to the alternate treatment. And what we essentially found is that biflongum 1714 reduced the morning salivary cortisol levels. Now, as everyone knows, cortisol is the main stress hormone in man, and this biflongum reduced morning salivary cortisol levels. The subjects didn't know if they were taking the biflongum or placebo, but when they were taking the biflongum, they reported themselves as feeling less stressed. So their cortisol levels were reduced and they reported themselves as feeling less stressed. Interestingly enough, and I think this was probably the first time it was demonstrated, we found electrophysiological changes when the subjects took the biflongum as opposed to the placebo. And we also found changes in a number of cognitive tasks. For example, paired associate learning was improved in the subjects who were taking the biflongum. So we had originally reported these alterations in rodents, but we found similar anti-anxiety and cognitive enhancing effects when biflongum was taken in healthy subjects. This is another study of this particular biflongum, and it was a study in students here in Cork, where over 2 semesters we studied them. And in 1 semester prior to their examination, they took either the biflongum or placebo. And in the 2nd semester prior to the exam, they took the alternative treatment. And we were looking at a number of parameters, but particularly sleep. And what we found was that when the subjects were taking the biflongum, their sleep duration was improved during the exam period. Now, there have been a number, our paper was published a few months ago, there have been another 2 or 3 papers with similar findings with different probiotics in recent months. Now, I want to stress the point that most probiotics do nothing. And this was a probiotic, Lactobacillus rhamnosus, the JB1 strain, that we had published a paper in PNAS in an animal model, and we found it worked wonderfully in rodents. But when we tested it in humans, it had no effects whatsoever on anxiety, on endocrinology, on immunology, or on any parameter we actually looked at. So not all probiotics work in humans. And of course, some things work wonderfully in rats, as we all know from pharmacology, and they don't work in humans. Now, this is, I think, an interesting study. And it was a study of another strain of Lactobacillus rhamnosus, the HN001 strain. And it's interesting because it's a placebo-controlled study in over 420, where 423 women were enrolled. And they took either Lactobacillus rhamnosus or placebo from the 2nd trimester of pregnancy up until the postpartum period. And what was essentially found was that those women who took the Lactobacillus rhamnosus as opposed to placebo had significantly reduced levels of depression and anxiety postpartum. Now, it's a finding that I think needs to be replicated, but I think it is a very important finding. We all know how high levels of depression and anxiety can be during pregnancy and then the postpartum period. Up to 20% of women suffer from postnatal depression or depression during pregnancy. Here is a potentially safe treatment, not involving medication, but resulting in a significant drop in depressive and anxiety symptoms. Now, there have recently been a number of meta-analyses of probiotic use in depressive illness. And this is one of them. It was published 2 years ago. And the conclusions really from this meta-analysis is that probiotics are effective in reducing depressive symptoms, and that multiple strains. Now, there have been a number of studies where they have used 2 or 3 strains of bacteria as opposed to a single strain. And what this particular meta-analysis concludes is that those studies using multiple strains, which we refer to as a polybiotic, where you have more than one strain, it's referred to as a polybiotic, that the polybiotics seem to be more effective than single strains. I personally would question that, but I think it is an interesting observation. It's also worth pointing out that probiotics do not colonize the gut in an adult. If we take a probiotic or a live biotherapeutic, it goes in the mouth and out the anus. It can have major physiological effects, but it does not colonize the intestine in normal circumstances. There may be situations where it does, but for normal, healthy individuals, it doesn't. And I think that's important because people sometimes believe that there's colonization, whereas there really isn't in your average adult. Now, prebiotics are bacteria which promote the growth of good bacteria. So they're fibers. They're fibers. Inulin would be the most highly studied prebiotic. It's a fiber that's taken up by good bacteria and metabolized by good bacteria and promotes the growth of good bacteria. On this slide here, you've just simply got a list of some of the sources of prebiotic fibers. There have been a number of papers published. Phil Burnett has published papers, so have we, showing that prebiotics can certainly reduce cortisol levels and anxiety levels in healthy individuals. So I think that prebiotics, may very well have a role. And of course, the use of symbiotics, which is a prebiotic combined with a probiotic, might indeed be a very effective way of dealing with stress-related disorders. There aren't too many studies using symbiotics in the literature. There are 1 or 2 small studies, but nothing major. Now, this is a study from Felisa Jacka at Deakin, and I think it is an interesting study. Felisa took a cohort of depressed subjects, and the study period was 12 weeks, and they were randomly allocated to either go on a modified Mediterranean diet or to receive intensive psychosocial support over the 12-week period. What you can see here is that if you look at the MADRS scores with the alteration in the diet, going on the modified Mediterranean diet, resulted in a far greater drop in MADRS scores than did psychosocial support. So I think it's one study. There are a number of other studies now as well, providing evidence that a Mediterranean diet, when introduced in depression, does augment any other treatment. Of course, we've known for a long while that people who are on a Mediterranean diet tend to have lower levels of depression. And this isn't just living in the Mediterranean region, because it does seem to apply to people, let's say, in Northern Europe who are on a Mediterranean diet as well. This was a European consensus document which we were involved with, and it really is a series of recommendations in relation to diet. Now, I'm not suggesting that diet alone is a treatment for depression. I use drug therapy all the time, and I occasionally use CBT as well. But I do think that dietary alteration can benefit people who are depressed. And what we recommend here is an increase in fruit and vegetable intake, a high intake of fermented foods, an intake of fish, and keeping red meat and processed meats to a minimum. So fruit, vegetables, fermented foods, and fish are regarded as essential for an optimal diet, either for the prevention of depression or in somebody who's being treated, let's say, with pharmacotherapy for depressive illness. So when we compare the depressed state from the healthy state, in the healthy state, we have a normal diurnal rhythm to the hypothalamic pituitary adrenal axis. We do not have inflammation, and we have diversity in the gut microbiota. What we've got in depression is a lack of diversity in the gut microbiota, a pro-inflammatory state with an increase in pro-inflammatory cytokines and acute phase proteins, and in many patients, an overactivation of the hypothalamic pituitary adrenal axis with high levels of cortisol. So in summary, ladies and gentlemen, I think it's reasonable to assume that gut microbes are essential for normal brain function. I think that there is increasing evidence that the gut microbiota is dysregulated in depression. It is part of the stress response. I think our view of the stress response previously has omitted the gut microbiota. I think it is an essential part of our stress response, our biological stress response. And I think that psychobiotics are certain live biotherapeutics, and I'm not saying all, have a role to play in managing stress-related disorders such as anxiety or depression. Thank you very much for your attention.
Thank you very much, Ted. And Stefano, could you take the discussion, please?
Yes, I'm pleased to take the discussion. I'm still thankful to Professor Dynan for his presentation. And for the importance of considering the whole human being in the assessment of his disease, especially in depression. So I completely agree. I wonder where we have a question here in the chat. We don't have questions so far specifically, but so I will take the occasion to ask myself a question to Professor Dynan. So you published in 2017 of a psychobiotic revolution that is still a very, very important book. But still, when we think about our everyday practice, I see that there is not much attention to the question of the growth and the assessment. Do you recommend to assess and how this function in the depressed patient?
The point you make is very valid, and I would fully share that view. What I would argue is that studies of the gut-brain microbiota axis are very new. I mean, this is a paradigm shift, really. I mean, there have been papers in Science and Nature. We had a big review in Science there recently, and there have been papers in Nature and PNAS from our group and from several other groups recently. I think it takes a long time for clinical practice to change, doesn't it, really? And what I do think is it's happening slowly, but I think clinicians, both psychiatrists and psychologists, are becoming more cognizant of the fact that diet is important. And if I was to put any message out there and forget the microbiota or anything else, my message to psychiatrists would be that really when we're treating our patients, whether we're using pharmacotherapy or psychological therapies, that proper nutrition is essential. And that really very often our depressed patients have a very bad diet. They eat a lot of fast food and highly processed foods. And it is much more difficult to get somebody better if they have a bad nutritional background. So I think things are changing very slowly, but I think that's usual. Paradigm shifts in medicine tend to be slow anyway.
Sigrid, do you want to add something?
Yes. I also thank you very much, Ted, for the follow-up to your lecture you gave at the last IFMAD meeting. Great to see that there is a progress. So you mentioned briefly also how you select this patient, but could you have also a selection of patients? Would you say, well, this patient really would benefit from a probiotic sort of addition? And in this line, I would like to ask you also, to my understanding, like at least 1/3 of the patients with depression, they complain about obstipation. So if a patient has obstipation, is this already a first sign that their probiotic diet should be implemented?
Indeed. Now, that's an interesting question. I am certainly of the opinion that the sorts of patients that you and I are treating severely depressed, I don't believe that they're patients who are going to benefit from psychobiotics. I really don't. I mean, I think that the evidence is emerging that psychobiotics may be beneficial for people with milder forms of depression or milder forms of anxiety that are in primary care. But I do think that the patients that you and I treat do benefit from nutritional advice, not just the introduction of a psychobiotic, but good nutritional advice. If somebody's in a bad nutritional state when they come to us with a severe depression, I think that our medication and our approach will be considerably improved if we give them nutritional advice. So I'm not advocating at all that psychiatrists like you or I who are treating severe forms of depression would simply be giving a psychobiotic. And I'm not sure that simply adding a psychobiotic to an antidepressant helps. Maybe it does, but I haven't seen solid data. I think that it is for milder forms of depression, and really with you and I, it's a case of giving people appropriate nutritional advice.
May I continue this question?
Please.
Are you about to change the Hamilton depression score? Because I think on item 15 it says, if the patient says his depression comes from a bad diet or it's like the seasons, then they are no insight into the disease and they get 2 more points towards depression.
Well, very well pointed out, Siegfried. Perhaps to get back to your previous point, though, you mentioned constipation, and of course constipation is a symptom for many patients, particularly elderly patients. And I do think the dietary alterations there, I think increasing prebiotic fiber intake undoubtedly helps in the management of that constipation.
Mm-hmm. And along this line, I keep asking you so many questions because you are so knowledgeable, Ted. So there are some medications like duloxetine. They cause constipation, right? And
yes.
That's a big problem for some of the patients, right? So then we have to stop this medication.
Indeed. Indeed. Well, we recently published a paper profiling most of the commonly used psychotropic drugs in relation to the gut microbiota. What do psychotropic drugs do to the gut microbiota? And of course, not surprisingly, Siegfried, given the fact that the initial antidepressants were anti-tuberculous drugs, many of the commonly used antidepressants like fluoxetine are potently antibiotic and actually knock out certain strains of bacteria in the intestine. In fact, the one drug that promoted increased diversity, which is regarded as a good thing, was actually lithium. We found that lithium actually promotes increased diversity. And of course, as you know, going back a long while, people have suggested that those on lithium may live longer than those of us who are not taking lithium. But it is interesting that lithium promotes increased microbial diversity and that quite a few of the antidepressants have a negative impact. And so, of course, we've published a number of papers on olanzapine, and olanzapine, which obviously causes terrible weight gain, tends to increase firmicutes and decrease bacteroidetes. So drugs that we commonly prescribe in our clinical practice have a profound impact on the gut microbiota.
Very good. So one of my clinically most relevant questions is also to the patients, do you have constipation usually or do you have more diarrhea? So I think this kind of question is not very often asked by psychiatrists. Usually patients, they look at me, oh, what kind of strange psychiatrist? You're talking about constipation. You should talk about my problems with the mother and so on and so forth. But for me, it's very important if the patient has constipation or not, or diarrhea. I think those are different patients. And of course, the choice of medication is quite different to these two types of
Indeed,
patients.
Absolutely. And of course, more and more gastroenterologists are using probiotics or live biotherapeutics to treat irritable bowel syndrome. So patients who have irritable bowel syndrome, there's one probiotic, it's bifenfantis 35624. And I think several meta-analyses have shown that that's probably the most effective substance out there for treating irritable bowel syndrome. So I agree with you. I think that there are fundamental differences between our patients who are constipated and those who might have diarrhea.
Okay. Stefano, I think we have to go along, right?
Yeah. So I think we have consumed all the time, so it was short. because the discussion was so interesting and actively participated. So anyhow, so thank you to all the participants today. Thank you very much for your contribution. I think that we touch, the new concept, that involve the model of low inflammation and not just, the neurotransmittorial imbalance for depression and anxiety. So as usual, IFMAD is still ahead of the time, and so we are opening something that comes directly from the research field to offer to the clinicians some reason to some more reflection and in everyday practice. Thank you to all.
Thank you very much, Stefano. We still have one lecture which we should chair. That's from Alan Young, Professor Young. Professor Alan Young will talk about the functional outcome of bipolar disorder. And of course, he's well known all over the globe, but the few of you who do not know him in person, he is the chair of mood disorders and director of the Center of Affective Disorders at the Department of Psychological Medicine in the Institute of Psychiatry and Psychology and Neuroscience at the King's College London, where he is also the head of school and vice dean for academic psychiatry. He has a large number of credentials. He participated in a large number of trials and consensus statements in UK, but also worldwide. And he is a clear leader in the field of depression and bipolar disorder. His research focuses on the cause and the treatments of severe psychiatric illness, specifically mood illness. And he is the immediate past president of the International Society of Affective Disorders, past president of the British Association of Psychopharmacology, and so on and so forth. He published a large number of studies and also book chapters, and received numerous very prestigious prizes. So, Alan, the floor is yours. We are very much looking forward for your lecture on the functional outcome of bipolar disorder. Please.
My name is Professor Alan Young, and I'm from the Center for Affective Disorders at the Institute of Psychiatry, Psychology and Neuroscience in King's College London. And today I'll be lecturing on functional outcomes in bipolar disorders. These are my disclosures. I work for King's College London. I'm an honorary consultant psychiatrist in the Maudsley and Bethlehem hospitals. I do paid lectures, advisory boards for all major pharmaceutical companies, and I have got grants from various companies and charities and governmental bodies as listed below. So in terms of functional impairment in mood disorders, this is predominantly mediated by cognitive impairment. This slide shows a survey of a representative sample of the adult population from various European countries, with a total of over 20,000. And the two major features which determine psychosocial impairment or function were cognition and embarrassment. Embarrassment, of course, reflects stigma and prejudice against people with mental ill health. But cognition is a regular feature of work which suggests it is a major cause of functional impairment. Cognitive impairment is involved in many mental illnesses. Cognition in humans requires the operation of intricate brain circuitry. Disturbances in this complex system, from the gene level to network communication, can result in cognitive dysfunction in the domains of attention, learning and memory, speed of processing. And many mental illnesses show signs of cognitive dysfunction because of dysregulation at some point in these different levels applicable to the brain. And there's a nice summary of this by my colleague from Florida in the United States, Professor Philip Harvey. Now, in terms of bipolar disorder, major depressive episodes, of course, occur in bipolar disorder as well as in MDD. And one of the 9 diagnostic criteria for a major depressive episode, as shown in the DSM-5, is diminished ability to think or concentrate nearly every day, either by subjective account, what the person says or observed by others. So clearly, cognitive impairment is a part of major depressive episodes which occur in bipolar disorder and in major depressive disorder. We can assess cognition very simply, subjectively and objectively, either by self-report, with complaints of cognitive deficits being common, clinician ratings, which is quite crude, or a wide variety of objective neuropsychological tests. Philip Harvey again points out that subjectively reported symptoms and objectively measured cognitive deficits are not consistent. So people may complain of cognitive impairment and poor function, but actually be functioning in both quite well, or vice versa. And if we look at the cognitive impairment of functional domains, things such as cognitive flexibility, attention, verbal fluency, working memory are of course key for our function as human beings, our psychosocial functioning. Now, what about the impact of cognition on functional outcomes? Now, this slide lists a number of ways in which cognitive symptoms can negatively impact all aspects of the patient's lives, but especially in the workplace. So in terms of work and school, a person may miss or forget deadlines, struggle to answer simple questions, struggle to complete even simple tasks, lose confidence in their ability to function, second-guessing their decisions and instincts at every turn. This also feeds through to effects on social life and family and personal life, where the person may be unable to fill their role in the family as a spouse or a parent and become frustrated and angry. And at times, this can be associated with emotional dysregulation. Now, in terms of the cognitive deficits, this does affect outcome. Cognitive deficits in bipolar disorder are consistent, reproducible, and clinically significant. Deficits in executive function, which is key to functioning in society, occur clearly in about 30% of individuals, and abnormalities are evident in working memory, attention, and psychomotor processing speed. As I've said, cognitive deficits are the principal mediator of psychosocial impairment, particularly workplace performance. And in terms of interventions which may help, there are pharmacological, behavioral, and neuromodulatory interventions which are being investigated as potential ways to help reverse or even prevent cognitive deficits. Now, in terms of the specific cognitive impairments in bipolar disorder, patients with bipolar disorder have cognitive impairments in attention, memory, and executive function. There is delayed verbal recovery of information, and this is the best cognitive predictor of poor functional outcome. This is a common complaint by patients. Cognitive impairments are related to episodes of illness that do tend to persist over time in euthymic or symptomatically recovered patients. And there's preliminary evidence of accelerated cognitive decline in some patients as the disorder progresses. So assessment of cognitive impairment is needed during a follow-up to plan personalized cognitive remediation strategies. Now, this review from a few years ago by Ledonowski shows the differences in the developmental trajectories of cognitive impairment between a typical healthy population and a group who developed bipolar disorder and a group who developed schizophrenia. These data are derived from the Dunedin study from New Zealand, where large numbers of children did simple pencil and paper tests in the first 10, 20 years of life, and were then followed up to see who developed psychosis or mania. Firstly, you can see the group who became schizophrenic had on average deficits that were detectable before the onset of illness. But after the onset of illness, these did not appear to markedly decline. Now, work from our group has shown that there's a gentle decline with decades, but this is reasonably modest. The bipolar probands, however, were much more normal in the developmental trajectory up to the first episode of illness. In actual fact, on average, they function better than the healthy controls. But the impairments in cognition and function came with episodes of illness. And this has been shown in numerous data sets, including our own, and in some that we've analyzed from China. So this holds the prospect that if we can reduce the number of episodes, we can perhaps help preserve cognitive and functional outcomes. Now, the first study looking at this that I'm aware of, first large study, was from colleagues in Barcelona, from Professor Vieta, who's of course one of the chair people of this group, which was published about a decade ago. This was functional remediation, and this was trialed in bipolar disorder, a single blind randomized design. Quite a large number of patients, about 240. Bipolar 1 and bipolar 2 patients from 10 centers were entered into one of 3 limbs: functional remediation, psychoeducation, the well-known Barcelona group model, or treatment as usual. And this was randomized. A FAST, or the functional scale, was used, and a score of 4 or more in the fast cognitive domain and 2 or more in another domain was required. Now, the difference between functional remediation and psychoeducation, these are very similar, but the functional remediation group had much more emphasis on functional outcomes and adoption of strategies to achieve these. The primary endpoint was the fast change from baseline, and this was a year-long study. Here you can see the publication, published by Torrent et al. In the American Journal of Psychiatry a few years later. And this illustrates the change in functional impairment scores before and after intervention in patients with bipolar disorder. First of all, you can see that there's a tendency for all 3 groups to be better. This is clearly significant before and after for psychoeducation, but significantly better for functional remediation. This is a very promising technique. I'm not aware that it's been followed up, but certainly it's worthwhile thinking about for future study. What about other cognitive remediation therapies for bipolar disorder? Because this is not only remediating cognition, but also potentially improving function. And indeed it does, as I'll show you with our own data. So multiple types of cognitive remediation exist. These aim to be restorative, to restore impaired neuropsychological function through practice, or compensatory, to compensate or bypass deficits through the learning of new strategies. And both may apply. Cognitive remediation therapy has been studied in a number of neuropsychiatric disorders, initially in schizophrenia. The effect sizes are somewhat modest. Effect sizes between 0.3 and 0.5 for cognition, and 0.2 to 0.4 for functional outcomes. These effects are durable up to 2 years. And because of the neurodevelopmental nature of schizophrenia, I think these are quite impressive. Up till we began to do this, there was only preliminary studies in bipolar disorder, but we've been focusing on this with our colleagues, particularly Professor Wykes, for the past few years. So we've applied circuits. This is a compensatory approach with emphasis on strategy use and the promotion of metacognitive skills or new strategies. There's personalized goal setting, SMART goals, which are reviewed throughout the therapy. And we link task practicing to daily life with the transfer of new skills and strategies to real life activities. And there's a review paper by Claire Reeder and one by Matteo Sella, who's another colleague who works with us in this from a few years ago that goes through this in greater depth. So just to say, this is how circuits is delivered. It's delivered flexibly. There's a website there that you can log on to that shows more. There are one-on-one sessions with a therapist. We do use Skype or Zoom or Teams, telephone, contact, and homework sessions. And there's practicing in the virtual environment of a village 30 cognitive tasks with multiple difficulty levels. And it's important that whenever the person has mastered one level, that they move to the next. So there's a scaffolding of difficulty. Circuits, as I've said, is validated in people with schizophrenia, and there's feasible and effective evidence that it improves cognition and functional outcomes there. So we did the cognitive remediation in bipolar study, or CRIB. This is the design paper, and I'll also show you the reference for the completed study. This is a feasibility and pilot study of cognitive remediation plus treatment as usual versus treatment as usual only. We asked a number of questions. Was this feasible? Is it acceptable? And lastly, does it improve cognition and function in people with bipolar disorder? Our sample was 60 people aged between 18 and 65 with either a bipolar 1 or a bipolar 2 diagnosis, and they had to be currently euthymic. And as I say, the intervention was cognitive remediation using circuits, 30 to 40 hours over 12 weeks. Here's the design, and you can just see baseline, randomization, and so on. Crucially, we took evaluations at week 13 and week 25. So in terms of the outcomes of this study, it was feasible. Only 7 participants, or 12%, were lost to follow-up, but most of these were in treatment as usual, and only 2 in the cognitive remediation group, which is quite striking, given it's a very large intervention that requires a lot of the person's time. No other missing data or assessment or non-attendance. It was feasible. You can see there was high degrees of completion and high degrees of satisfaction. Strikingly, 95% of the people who had cognitive remediation felt they'd improved, 100% like their therapist, 86% thought there was the correct number of sessions, and 76% agreed that cognitive remediation increased awareness of their limitations. But this was rated as being helpful rather than frustrating. Now, if we look at the outcomes, I'm going to separate these into cognitive and then functional. This is an intention to treat analysis. And you can see it's color-coded with blue and green. Blue is significant at week 25, but not week 13, so perhaps more later onsetting. And green is significant at both week 13 and 25. And you can see in a range of neuropsychological tests, there really was an improvement, certainly at week 25. The hotels test appears to go the other way, but that on the hotel test is a significant improvement. It's just the way it's scored is slightly different from the others. So good evidence that for bipolar disorder, this form of cognitive remediation produces improvement in cognitive performance. The functional effects, we did an intention to treat analysis. The FAST total, that's the same scale as used in the Barcelona functional remediation study. The GAS and the UPSA, which is a US scale, again, all showed improvement. So you can see FAST, although it's scored the other way, that's an improvement in FAST at week 13 and 25. The GAS, improvement on week 13 and 25. UPSA, improvement in week 13. You can see it just touches the line and therefore misses improvement in week 35. But really good evidence of significant benefits on function. So to conclude, functional outcome in bipolar disorder. Cognitive impairment occurs in a range of neuropsychiatric disorders, including major depressive disorder and bipolar disorder. Cognitive deficits endure beyond illness episodes and can be a long-standing feature of the disorder. Cognitive deficits may constitute an aspect of bipolar disorder and MDD that is independent of and dissociable from depressive and manic symptomatology. Most importantly, the real-world impact of these deficits is considerable and impacts greatly on people with bipolar disorder's functional outcomes. In fact, I would go so far as to say that along with comorbidities, it is the major determinant of functional outcome. Screening and assessment of potential cognitive deficits and cognitive decline over time are important in the clinical management of mood disorders, particularly bipolar disorders. Therapeutic studies in this area are limited, but I've gone through two of the most recent studies, the functional remediation study from Barcelona that was published about 8 years ago, which showed an improvement using the group technique that was of similar magnitude, but perhaps slightly greater than standard psychoeducation. The question remains as to whether this could be replicated. We've also done a study looking at the circuits, cognitive mediation in bipolar disorder. We've just published this. We've just got a large grant to do a follow-up study. This showed quite pleasing benefits on cognitive function from the cognitive mediation program, and also really quite striking improvement in the scales which measure functioning. And this was also highly acceptable to patients and very feasible. So patients engaged with this, they liked it, and they felt it helped them improve both their cognition and their functioning. So to summarize, functional outcomes in bipolar disorders are potentially remediable and tractable using these techniques. Now, there is evidence for benefit of pharmacotherapy, which I've not reviewed because of the pressure of time. But in future, it would be interesting to see the combination between the optimal pharmacotherapeutic regimen or drug for cognitive impairment with the optimal cognitive mediation strategy and how this impacted on functional outcomes in bipolar disorder. I will stop now and thank you very much and look forward to taking any questions.
Thank you very much, Professor Young. We had Professor Young on pre-recorded lecture, but we have the privilege to have him here in person to answer some questions which are evolving. And I would like to ask once more the participant to send in questions on the online participant live session questionnaire. And before I see these questions, I would like to ask on a very practical level to Professor Young, how do you select patients for your cognitive training? Could you give an advice to clinicians whom they should specifically send to this program?
Yes, thank you very much. So there's an important criteria, which is that the person with bipolar disorder must be euthymic, because particularly depressive symptoms, but also mixed and of course manic, do interfere with the performance of cognitive tests. So it's very important that the person is euthymic. My own view about euthymia is that this needs to be verified prospectively, and usually we like people to be euthymic for a period of weeks before accepting them in. That's not to say that they might not have some small degree of subsyndromal symptoms, but euthymia is key. The other major issue which bedevils the field is whether there needs to be a degree of pre-existing cognitive impairment before the person would benefit from cognitive remediation. Now, that sounds fairly straightforward. You would expect the person to have to show cognitive impairment before they would benefit from cognitive remediation. However, it's not quite as simple for bipolar disorder, because many people with bipolar disorder start off with superior functioning, as I showed in the trajectory graph, and therefore they may be performing at an average level or even above average, and this is still a drop-off from what they were pre-morbidly. Now, the International Society for Bipolar Disorders has a working group in cognition. I'm a member, and previously we've said that you should have to show decrements of about a standard deviation in a couple of tests before going into cognitive trials for cognitive remediation. However, the data from our own study, which we've analyzed since producing those guidelines, shows that people can benefit even though they don't have this obvious level of cognitive impairment. So I am quite open to including anyone with bipolar disorder who is euthymic and who feels that they have some degree of subjective cognitive impairment or is willing to take part in the study. And as I say, we're still analyzing the data from our own cognitive mediation study, but it doesn't hold up the previous ISBD guidelines.
Thank you very much for this clinical, very relevant question. Before I see the questions coming in again, I would like to ask you, you very importantly stressed the euthymic part. I think that's kind of new for all of us clinicians because we might want to start already a little bit earlier. But I think, as you clearly said, it's the key point that there needs to be euthymic, and you suggested 8 weeks. What about medication? Do you also say, well, like if a patient is on an anticholinergic sort of medication, olanzapine, let's put it this way, or other medication, would you before stop this medication before you go on with the cognitive training?
Yes, thank you, Professor Kasper. That's an excellent question. So, in general, at least in my experience, many patients blame the medication for the cognitive impairments. But I think that's probably not true for most medications most of the time. So the exception is the old first generation antipsychotics, which clearly reduce processing speed, and some of the more anticholinergic tricyclics and so on. And of course, as you've said, other anticholinergic drugs that would have effects. But of the modern drugs, the effects on medication appears to be marginal. The effects on cognition of medication appears to be marginal. And this is true even for our oldest drug, which is lithium. Now, many patients would say to me that lithium takes away, dulls their cognition and so on. My usual opinion is that this is because lithium is stabilizing their mood and they like to be a little bit hypomanic. And our colleague in the United States, Professor Katie Burdick in Harvard, recently published a paper in Neuropsychopharmacology, which I didn't have a chance to go over, showing that people who go on lithium actually have improved cognition. Now, this wasn't a randomized controlled trial. There might be other confounding factors, but certainly lithium appears actually, if anything, to be associated with good cognition. There are a number of other clinical factors which are associated with poor cognition. So obviously there's neuropsychiatric causes, including head injury. There's comorbidities. We've heard a lot from Professor Dinan about diets, and of course, related to this is obesity, and related to obesity is things like sleep apnea, and that causes problems with cognition, and also sleep impairments, sleep problems, which are very common in mood disorders. And we've recently just done a big systematic review that we're submitting for publication to show that there's actually quite a knock-on effect of disturbed sleep on cognition. So all of these things should be considered by the clinician. But drugs are usually blamed, in my opinion, too much.
Okay, that's a very important statement. Professor Pallanti, would you be prepared to make a final comment to the 3 sessions which we had the pleasure to chair together? Please unmute you.
Thank you very much. Yes, thank you, Sigrid. For really a pleasure to listen to all these 3 presentations. All of them was in line with the cutting-edge information, and we focus on different aspects. On the first one, where we focus on the difficulty and the discovery of new anti-anxiety treatment and difficulty of evolving of medical treatment for this condition. But the following presentation of Professor Dinan opened a new possibility to improve the life of this patient with mood anxiety disorders. Tend to this approach when involve probiotics, so we clinicians know that they can enlarge their comprehensive assessment, involving also the part related to metabolism and eating behavior. And the last one also is interesting because the approach is centered on the cognitive features of bipolar disorders, putting the cognition at the center of the outcome and treatment of this patient, and attracting the attention of the clinician on this part that usually is not really the first one to be assessed because of the presence of symptoms, but because also the setting that we had most of the time, because we most of the time we see this patient in the emergency department and emergency situation, and then instead this is a recommendation to follow up a patient and to work on that on the long term to really regain a position in society. So thanks to all of the speakers today, and thank you, Siegfried, for giving me the opportunity to make these conclusive remarks. Thank you so much.
Thank you. Bye-bye.
Bye.
Okay, hello everybody. My name is Borwin Bandelow and I'm chairing this session together with Stuart Montgomery. And may I introduce to you the next speaker. She's Carmen Moreno. Carmen Moreno is a clinician, researcher, and associate professor of psychiatry at the University Complutense of Madrid, Spain, working at the Institute of Psychiatry and Mental Health and since 2006. And she has focused on the neurobiological underpinnings of early phases of psychosis, other severe mental disorders, and the development of specific interventions. And she is currently the coordinator of the Child and Adolescent Program of the Spanish Center for Biomedical Research in Mental Health, CyberSem, and the co-chair of the Child and Adolescent Neuropsychopharmacology Network of the ECNP, and a member of the EMPRA network together with the EMA. And she is going to speak today about the mental health effects of COVID-19 pandemic. Please, Carmen, start your presentation.
Thank you very much for the possibility of presenting today. Let me check if we can see that. Okay, you can see my presentation, right?
Yes.
Perfect. So these are my disclosures. I'm going to focus on the mental health effects of the COVID-19 pandemic today. This is a topic that has been widely researched recently, but we still doesn't have that many sound data. So what I've done is just try and bring here the most updated meta-analysis of the data we have, and to bring a comprehensive perspective of the different aspects that should be taken into consideration when talking about mental health disruption. So first of all, we need to set the stage knowing that we are not in such a very good shape when it comes to mental health, even before COVID. But what happened after COVID started was that most clinical services, clinical mental health services, really went broken. This is some data from the WHO. Last year that says that 90% of countries worldwide really had problems in their mental health services, up to 60% of their mental health services, and some of them, the clinical, most important ones, such as the emergency or the critical harm reduction services, were disrupted. There was no increase in the expenditure of mental health, even knowing that there was going to be a problem, as we are going to see now. And we were already concerned last year. So we decided to convene a group of experts and of users and to prepare a proposal from Lancet Psychiatry, just to try and understand what had been done in mental health up until then and what will be needed for the months and time to come. And from this work, we concluded that some changes in mental health access would be needed, and that we should be preparing the floor for new mental health users that we envisage that were going to be some of the people that would need mental health treatment. Of course, this entitles the need of having mental health services that are flexible, that can adapt to the changing scenarios. What have we seen in referrals to mental health so far? So these are data from the UK, and you can see here that from primary care, there's been a reduction in mental health referrals. This, of course, is from the first months of the pandemic. You can see here, this is March 2020. So from primary care to mental health, there was less referrals. People didn't go out of their house. There were problems accessing primary mental health. But those people that came to mental health services were referred to secondary mental health. Probably the exception was children and adolescents. Disruption in their services was striking, more so than in other populations. But there were people needing to have treatment, and these are data from emergency room services. So we can see this is the same date that I mentioned before, March 2020, and you can see that there's an increase in mental health users of emergency room services, and also increasing in those people that came with overdoses. So probably what happened is that we were seeing different means by which people were accessing our care. What do we know about the prevalence of mental health problems, the changes that have been, the prevalences of mental health problems in the general population due to COVID, or in the era of COVID? Okay, this is some of the latest data. This is a meta-analysis including 66 studies, more than 200,000 participants. And we can see here that the most reported outcomes were depression, anxiety, distress, and insomnia, and were in the range to 31 to 41%. And they were more important in those people with chronic diseases, even non-infection chronic diseases, and those people that had been quarantined for longer periods. And also in some important population that are those that were mental health providers, physicians and nurses. When it comes to what happens with quarantine, that has been identified as one of the main probably predictors of bad mental health outcomes, we can see that the odds ratios for anxiety, for depression and stress are between 2 and 2.8 when considering all people that have been quarantined. And we can see that there's an increase on these mental health outcomes when containment duration is longer than 1 week. So in many countries, we've had really much more longer containments, and people hadn't been allowed to be out of their houses, even for very brief periods, for a longer time. So this seems to have been probably useful and useful complicated in terms of mental health. We've seen that those people with previous vulnerability, psychosocial, with previous mental health problems or stressors, really had more risk of these mental health outcomes due to that. There were also some protective factors. These are data from our colleagues in Hospital Clinic Barcelona. And we can see from their work that regarding the general population, we've seen that there were some predictors of lower anxiety symptoms, such as those people that were able to maintain a healthy diet and not being so exposed to reading COVID news and updates. And also would predict sort of lower depressive symptoms together with the previous ones, following a routine, pursuing hobbies, staying outdoors, those people that were able just to maintain an organized life. In patients, we see something similar. Those people that were able to be pursuing hobbies or to have a good level of organization in the family had more resilience, a more resilient profile. We also know that those people that were not able just to maintain their mood stable, those that were having depressive symptoms were also having more difficulties in their outcomes in general. What happens with the suicidal behaviors? This is getting a more and more important issue nowadays. There's no clear data on suicide completion so far, but what we can see is that the studies told us that there were high rates for suicidal ideation. We are talking about almost 12% in the community, 11% in clinical, and 7% in frontline samples, with suicide attempts ranging between 2.6 to 10.7, depending if we go from community to clinical samples. The rates of self-harm have been higher and even higher in people in young populations. We see that these are the moderators that really have impact on the suicidal behavior, female sex and young age. This probably is something that will need to be studied in more depth. And we can have an idea that there must be a trend, but it probably is too early to talk. What happens with people that already had some mental health problems, or what happened with the predictors of mental health problems? How do they impact the effect of COVID, or how do they impact the effect of being infected by COVID, that we know that is also a predictor for mental health? So there's a number of factors. I'm just going to mention briefly two of them that I think are important. One is that we know that people with severe mental illness already are exposed to psychosocial factors that also can expose them to higher COVID-19 infection rates. And that's a problem because there's an addition between these two situations. And we also know that some of the treatments of COVID-19 may involve the use of high doses of steroids, for example, that can increase also mental health problems, even briefly. Some ideas of some genetic polymorphisms that can be associated with mental health problems and immune dysfunction are there. That's not that clear that are having any impact on what we are seeing now. In any case, COVID-19 is a virus that goes to affects the brain in two ways. It's a neurotropic virus, and on the other hand, it also causes a peripheral inflammation that we know that has the possibility to increase or act as a risk factor of many mental health problems, depression, psychosis, PTSD, etc. So knowing that, there's been some people that had COVID infection, and it's nowadays one trending topic just to know that these people tend to have some symptoms, particularly anxiety, depression, that last longer than the COVID positive test or the official COVID infection. This has been called the post-viral syndrome, and there's been some sort of like differential symptoms, such as the migraine-like headache, the loss of taste of smell, and the cognitive impairment, together with anxiety and depression. This is a problem at the hospitals. We've seen that there's a number of patients that are requesting consultations with psychiatry, and we have created in many places programs to be able to treat these patients, prioritizing those with severe illness during the acute COVID-19, with advanced age and with presence of organ comorbidities, because they are at higher risk of developing these symptoms. We also know that people that have had infection of COVID, it seems to be 6 months after this, having these infections, more likely to develop neurological and psychiatric outcomes. Up to 62%, and this is the largest study to date, may have some of these symptoms. The numbers are even higher in those that had received intensive treatment in the intensive treatment units. And you can see here, because COVID is the red one up here, you can see here that when there's difference, when we make the comparison with other illnesses, even other respiratory illnesses, COVID beats with those mental, neurological and psychiatric outcomes. And here you can see that there's also higher increase in those that have had any kind of encephalopathy. So those most severe have worse outcomes, mental and psychiatric outcomes. Another population that should be taken into consideration, and probably for the years to come, are those that lost a relative. And these are preliminary data from a cohort we are following, where we can see that up to 40% presented depressed mood, anhedonia, up to 38% some symptoms of separation anxiety, and up to 37% significant functional decline. These are more important in those that were losing relatives that were more severe following treatment in the ICU, and in those people that already had mental health problems. So we can see here an addition of risk factors for developing problems of mental health. People that already had mental health problems have been very worried about what would happen to them. We've seen this disruption in mental health services. People have been very worried about being infected and being worsening of their mental disorder, not being able to receive treatments. And probably this is interesting, that knowing that data really aligns with these ideas. We see now, we have data now to show that those people with ADHD, bipolar disorder, depression, schizophrenia really are at an increased risk of COVID-19 infection. These odds ratios go from 7 up to 11. So really much more likely to be infected than people without mental health problems. And particularly for some of them, there's also higher risk of having very bad outcomes. These are data from New York, where you can see that those people with schizophrenia spectrum diagnosis were at increased risk of mortality following a positive test of COVID-19. Recent data shows that although schizophrenia is at the higher risk of that, having any pre-diagnosis with mental disorders worsens the prognosis of COVID. And it's also the severity, but also the mortality, what's worsened in this population. Some of these data have been used to advance vaccination from people with mental disorders, COVID-19 vaccination. And as we saw before, there's some concern of mental health, providers of health providers regarding mental health outcomes following COVID. This is a meta-analysis that we performed some months ago, where we can see that those people infected with coronavirus had worse physical health and also worse mental health than those that were not having these professions. And this data from Spain, and this is a cohort of people, hospital workers, that were recruited right after starting the pandemic from May to July 2020, that were evaluated through web-based self-reports on ideation, suicidal ideation and suicidal behaviors. We see that this is also a worrisome outcome. The suicide behavior prevalence were 8.4%, less active ideation than passive ideation. And we know that the association of developing this suicide behavior had to do with pre-pandemic lifestyle mood or anxiety disorders, but also with some significant modifiable factors, such as the perceived lack of coordination, of communication, or supervision at work. Everything having to do with the difficult work situation that we as healthcare providers had during these months. Okay, so with that, what should be done from now on? What will happen with the adaptations that had already been in place? Will they help really to maintain mental health for the months to come? One of the adaptations that had been more useful, and you can see this now in this course, for example, we wouldn't be able just to be having this conversation without things. So telemedicine is one of them. We know that we've had the opportunity to make phone calls, video conferences. We've had the opportunity to refer our patients to self-help therapies that were developed but were not that widely implemented only 1 year ago. There were some previous barriers, and most of these barriers were not in the users, but in the personnel, and now there's less and less, there's much more access. There's still some digital divide and some people that do not have access, but this is something that we'll have to work through, and it's being worked through in the last months for sure. And there's also still some issues in the privacy and security of these means. But in any case, this is something that will stay. And the problem now is to decide when coming to the clinic starts to be easier than now, who will need and who will not need having telemedicine, or how to decide what's best for each one. And for deciding that, we'll have to know a little bit more than we do now, and we'll have to ask patients and users what are their experiences and what they would like to get out of these situations. Another thing that has become very interesting, and I think that I'd like to point that out, has to do with what has happened with some important treatments, such as those treatments that really ensure that people follow with the treatments, long-acting treatments, for example. So there's two examples here of what has been done in different countries or in different places. On the one hand, there's some example from Romania, where there's been a dramatic drop in the administration of these medications, and some of these the reasons had to do with patients that were worried not to get treatments because they are expensive, to run out treatments on a country basis. So they asked for switching to the oral formulations. They were sure that it would be easier just to not to run out of supply of this oral formulation. And in other places, these are data from Pittsburgh, they decided to increase the people that were in charge of the clinics that were able to provide these long-acting treatments. And they didn't lose more than a little percentage of those users. And probably this is the way to go, to make sure that when you cannot provide everything, at least treatments, you should be able, yes, to make sure that you make people to be able to continue treatment. So to finish, we'll have to think through, knowing that there's been an increase in mental health problems, that it will be sustained. We'll need to think through what has happened in the way we provide mental health to our patients. We've been able now on doing some things that may seem negative, such as focusing more on physical health and mental health, in physical distance. We've had less opportunities for monitoring treatments and some premature discharges. But even these situations may turn into positive. We have had the opportunity of having more room for mental health education and an opportunity for improving self-care and coping strategies that were within the patient's networks, and a possibility of leveraging technology and being able to reassess the need of some treatments, such as the long-acting treatments that I mentioned before. So to conclude, I really think it's difficult to think that COVID-19 did not impact mental health. We already know, we've had many examples, and I hope that with this overview, it's even more clear that it's not only in the populations that we consider vulnerable previously, but in new populations. We know that people with mental health problems are also more vulnerable to COVID-19 and its consequences, and this we will need to focus on these populations from now on. We know that people that are survivors of COVID-19 will have more needs on mental health, and we'll have to adapt our system, otherwise we will not be able to face the potential problems that may come. It's an opportunity to rethink our models of assistance and to rebuild them on the face of this situation. Thank you very much, and I will be very happy to take questions.
So, muchas gracias, Carmen, por su presentación excelente. Thank you very much for your excellent presentation. So, I don't see too many questions from the audience. Please ask your questions right now. So maybe Stuart, do you have a question for Carmen at the moment?
Yes, I thought that was a very interesting talk, Carmen. Thank you very much. And concentrating on the long-term follow-up of COVID patients, I noticed that effects you said were seen up in the 6-month period when you looked at. We have in the UK a concept of long COVID applying to some 10% of those who are unlucky enough to be infected. And it looks to me from your data as though the effects are seen in multi-systems, not seen in hematological, seen neurological, and in psychiatric as well. We know that it affects other systems in the body as well. And I don't think this is very well known to the population, particularly to those who are refusing vaccination. I wonder if I could have your comments.
I really think this is a very important issue, and it's going to be even more important in the months to come. There's some controversy now in the field between neurologists and psychiatrists about how to mention or how to name this syndrome, but there's no question that mental health outcomes are there and that are increasing in that population. If this has to do with the neurological effects of the virus, if this has to do with the effects on the multi-system, or if this has to do in their adaptation after the COVID situation, probably it's going to be something to research in the upcoming months. But what is clear is that we are really providing now services to this particular population. We are having many referrals in our consultation liaison services for these particular people, and not only to these people that were in the ICU, also to the people that apparently were not that severe. And after having a negative COVID tests, they start to come to the psychologist or to the psychiatrist, and there's this situation of not being able to face life normally as before. So really, I think it should be more stress, and I know, in particular, in some countries, we are having this problem with people that do not want to be vaccinated, and I really think if they knew the consequences other than the fever or whatever that they may have on their quality of life, this also could be a possibility for rethinking what to do with that.
Thank you. That's a very useful summary of the situation, and I'm very pleased to hear it. You said in your answer there that you thought it was seen not just in those who are in intensive care units, those who have it severely ill, but it's seen also in those with mild illness. Do you know whether the proportions are similar or not?
There's more, the proportion is higher in those with ICU, that's for sure. But the problem is that most people will not go to the ICU. So even though the proportion is higher, samples are disbalanced. So at the end, you've got more people with those problems among those that didn't go to the ICU.
Yeah, thank you. Bowen, do you have any?
Yes, I'm the anxiety expert, so I have a question on anxiety. Everybody asks me, is there an increase in anxiety? But we have to differentiate between anxiety disorders. People with anxiety disorders are always afraid of things that are not dangerous, like spiders or public speaking. And I don't see such an increase in our hospital. Of course, we see an increase in real anxiety. You have to be afraid. But what I think is there are not enough anxious people right now, because we see from some countries like Israel or the United States that the vaccination stops at like 70% of the population. There's 30% of people who do not have enough anxiety because they're still not afraid to get COVID. So how can we manage this, that too many unanxious people?
Yeah, I mean, I really think that probably we should make them anxious by other means. So probably health is not what is going to make them more anxious. But I'm sure there's another means just to let them know that they should be anxious if they don't really, if they are not really clever with everyone's health. So maybe other means should be implemented, and this I leave that to the governments, but they should think through another options for pursuing this vaccination.
You are aware in Spain of the efforts of President Macron in France, making vaccination compulsory for healthcare workers, and that vaccination allows access to large meetings. Do you approve of that approach as a non-anxiety raising issue to persuade people to take it?
I mean, what I'm saying is that you need to put public health first. So if you are allowing people who is potentially transmitting an illness into a potentially problematic situation, you have a problem with public health. So it's not about taking away freedom. It's about making sure that freedom is there and that these meetings can go on, and that these situations can go on. So it's about the perspective, and of course people is free not to continue working in some places, or is free, people are free not to go to some meetings. But if you go there, then you need to people need to make sure that you are not going to transmit a disease that can potentially affect most of the people who are attending the meeting.
Okay, I think we have to close this session. It's 4 o'clock. And so I hand over to my co-chair, Stuart, to introduce the next speaker of the next session, Philip Gorwood.
Thank you, Dr. Marino. Excellent talk. It's my honor and privilege. Oh, hi. Nice to see you, Philip. It's my honor and privilege to introduce Philip Gorwood, who is well known to everybody as in his various roles, and a European psychiatry president, various other situations like that. He is a head of psychiatry in Paris, and I look forward very much to his talk disassembling long-term depression in terms of whether it's episodic or not. Thank you very much, Philip.
Thank you all. Thank you, Stuart. Very nice to see you in good health. I loved also that you gave France as an example for the way to deal with COVID. And I loved also the point that psychiatrists are now promoting anxiety as a way to cope with these difficulties. So thank you very much for an interesting topic, which was a little bit difficult, because depression is, of course, an episodic condition, but of course, it's not only an episodic condition. So it really raised important questions for clinicians. So my name is Philip Gorwood, and I'm working in Paris, France. And the point to discuss is, what kind of model should we use for depression? Would it be like allergy and migraine, where depressive disorders are the expression of an episodic disorder per se, with maybe possible and secondary stigmates that sometimes lead to chronicity? Or are we instead more in favor to propose depressive episodes at the top of an iceberg based on a persistent condition with more and more obvious symptoms with repetition? And that would be more the model of diabetes and hypertension. So when you look at this beautiful data from the Danish country, where they have 25 years follow-up, because this is the possibility they have to follow each condition for a very long period, and on the whole nation, which means 17,000 depressive episodes, you see that after such a very long follow-up, only half of these patients have another episode. So for at least half of patients, it is an episodic condition, because you will not have it anytime during lifetime afterwards. So no doubt this is an episodic condition. Okay, but when you say so, it means it's not chronic. You are either one or the other one. And on this aspect, there's a lot of difficulties, because episodic conditions have to be compatible with the distinguishing of persistent depressive disorders that are now having specific titles and criteria. Most of the day you are depressed, most days are not, and for at least 2 years. A number of symptoms that are required, and never without symptoms for more than 2 months ago. So it's really chronic. And when you look at the subgroups of those persistent depressive disorders, one of them is recurrent major depressive disorder, of course, without recovery between episodes. So how are we going to deal with this? We do have episodic, which is not chronic, but within the chronicity, we do have also episodic conditions. Not exactly different with the ICD-11, which is still to be developed, as we have this current depressive episode with a single one, with a possibility to distinguish those with persistent symptoms, which is then closer to chronicity. Okay, so if those are really entangled, we have to try to see what can help us distinguishing these two conditions. There was a nice review in the Lancet Psychiatry being published on this topic, really a global review of this aspect, and a long list of scientific data shows that we do have distinction between episodic on one hand and chronic on the other one. But when you look at those very specific that are really at the border of chronicity and episodic, you see that, for example, you have a higher risk to have a chronic disorder when you have a higher rate of depression, which means more episodic in the past. So it is not possible to completely distinguish these two aspects because, in fact, higher episodic depression is also a risk factor for chronic disorder. And when you look at the predictive factor of chronicity, it is also for recurrence. So that's the other way around, where chronicity is also a risk factor to have a new episode, which is then recurrence, then episodic. So do we have a strictly defined distinction between the two? When you have a follow-up of those patients that were initially having a completely episodic depression and the other one with more chronicity, on the follow-up, you see that there is a crossover, where when you had initially more chronicity, you increase the risk for a new episode. And on the other way around, having an episodic depression, at the end of the day, increases the risk of depressive episodes, at least more than controls. So really, they are really entangled concepts. You might say, well, this is maybe a question of subgroups of depressive episodes. So such, for example, dysthymia, which is or a very specific type of depressive episodes. When you look at family aggregation study, they showed more depressive episodes in first degree of people with dysthymia. And when you look at, with follow-up patients with dysthymia, you nearly systematically find one depressive episode. So even when you look at specific subtype of depression that are more or less connected to the concept of chronicity, you see that you have more relatives with episodic form of depression and at least one episode in the concept of dysthymia. So it's really difficult to disconnect. Maybe a way to do so would be to use antidepressant treatment response. Just to give you one example with the role of SNRI, because it really looked at the three aspects of chronicity, highly recurrent or first episode. And you see with the effect size that it was relatively equivalent. Doesn't mean it's the same for any type of antidepressant treatment, of course, but just to give you one example where one of the treatment aspect, which is one of the way we try to disconnect those different disorder, might in fact be relatively alike. And that's the case for SNRI in this treatment. So I hope I created a lot of confusion now. Is it episodic, phasic? Is it chronic? How should we do that? Well, interestingly enough, when you look at episodic concept, you are looking at phases. And phases, of course, resonates with the idea of seasonal affective disorder, which we all know is also very clearly more frequently observed during winter and then closer to the concept of episodic disorder. But on a high prevalence study, there's been an assessment, once again, in these Nordic countries where you have so much data, that the frequency of occurrence of a disorder is much higher in winter compared to summer, which is of course not a surprise for all clinicians. But just have a look on this conclusion of this manuscript saying that in January, you have 70% higher rate of depression compared to August. So this would be really in favor of an episodic aspect. So how then can we cope with this first study showing that it's an episodic phenomenon for half the population? Okay, but in this study, I wasn't completely fair. I just show you those with the first episode. Let's go for the other ones, those ones that already not had the first episode, but 2, maybe 3, sometimes 4, and even 5. Then you see that the risk to have another episode after this fantastic follow-up of 25 years gets higher and higher and higher systematically after each episode. Even with those having 10, the risk to have another episode is 100% closer to the concept of systematic presence of depression, which is, in fact, not far from chronicity. So we have an episodic phenomenon which gets worse with repetition. So we have to reconcile this conflict between episodic disorder, but getting progressively chronic with time. We have a lot of risk factors for that are really well known by all clinicians. The severity, even the initial one, the duration of the present episode and the number of episodes, the comorbidity, some temperaments such as harm avoidance or neuroticism, the level of social dysfunctioning, and different cognitive abnormalities. But all those risk factors, there are in fact more and more now very clearly connected to the number of previous episodes, which is then explaining this kind of vicious circle that we saw with the increasing speed of risk with time. Just give you a couple of examples where we showed, for example, that the memory skills, the narrative memory skills is getting lower with the repetition of episodes, even if you take into account many different confounding factors such as age or the level of comorbidity, use of benzo, and so on. It's a very solid finding. When you look at psychomotor retardation, for those patients that were initially depressed, but then are being completely recovered with no more remaining symptoms, then being protected with these remaining symptoms, it's more or less the same for the first 3, but afterwards, you get slower and slower with the repetition of episodes, explaining why, for example, you might be more fragile and then having a higher risk to have another episode. One of the explanations is about the risk of having more frequent episodes and a lower treatment response because of a personality disorder. And that's really a side of the cyclicity and the episodic nature of depression. We try to challenge this aspect, looking at not presence or not of a personality disorder, but the risk of having a personality disorder with a score. It's a very simple to use instrument, the SAPAS, couple of items, and it's very nice because it's also correlated to the severity of personality disorder, even though it is meant to detect a personality disorder without precising which one. And what we found is that the poor response to treatment was, of course, correlated to past depressive episodes. And this link was captured by the SAPAS score, which means, in other words, that repetition of episodes worsen personality disorder, which damage treatment response. So it's another, and there's so many now, way to see that the repetition of episodes might have different kind of damages, explaining why it's more and more difficult to treat and more frequently repeated. Of course, these are really about medical, epidemiological, and clinical aspects. Some of them are more phenomenological, and I was really interested in this review saying that how phenomenological approach can explain the shift to chronic aspect. One of them is the higher rate of socially avoidant behavior. The immediate explanation we have afterwards is that when you have more episodes, you have more remaining symptoms of depression. And that would be one way to understand why those patients are being at higher risk of recurrence and then, of course, have a poor functionality. The point is, as soon as you have a subthreshold depressive symptom after the first episode, it is now very clear that you increase the risk of recurrence, and that is 12 times faster. And the duration of inter-episodes where you are well is shortened by 7 times. So there's no doubt that looking at these depressive symptoms is extremely important and then could explain this phenomenological aspect that was developed. Another way to look at that is looking at cognition. I love this study, which was on a limited sample, but I think it's really very beautiful. It's a very simple track. You're looking at where your eyes are looking at on your screen. It's a tracking system. And so when you see some faces having no emotion or positive or negative one, and you just look at the time you spend in the core features that help you distinguish what kind of emotion has the guy in front of me. When you see at those that were never depressed, that's the blue curves, they pass very low time on negative aspect. This lady seems very sad. I don't want to look sadness everywhere, so I'm not taking a lot of time on that. And when I look this happy guy on the right, I'm going to spend time because he's smiling, a nice face. I like it. When you are really depressed, then of course this sadness resonates, and then you are spending a lot of time with these red curves on the sad face, and you are not interested in the happy face. And look at those that had the depressive episodes beforehand, but now are being remitted. So this is not explained by remaining symptoms. It's just intermediate. And that might be a good way to see this kind of stigmate, a vulnerability, acquired vulnerability because of past depressive episodes, where you see sadness more around you because your cognitive bias are going to focus on these negative aspects and then might explain this kind of vulnerability. Of course, there's a large set of biological approach, and I won't get into too much details for the sake of time, but I think that we are getting closer now to very interesting finding, maybe because we have now got out about just genetic vulnerability that doesn't change, but more about oxidative stress, more about the energy coming from mitochondria, more about the epigenetic stigmates, because what occurred in your life have an impact on your genome through epigenetic regulation, and also with this fantastic boost of inflammation in being involved in psychiatric disorders. So let me proposing something completely stupid. Why don't we call it not chronic? It's wrong. Not episodic, that's also wrong, but stagic, it doesn't exist. So a kind of staging disorder. Of course, staging has been analyzed in depression. There's been one nice study published in the journal Clinical Psychiatry where they have proposed 8 consecutive stages, where 0 is completely healthy and 8 is completely chronic. And of course, with intermediate step, they followed those 200 participants for 2 years, and they found that all the models fitted very well. So definitely that's a good way to reconcile those 2 aspects of episodic and chronic with this kind of staging approach in the 2 aspects. Let me conclude my presentation with something a little bit funny. My basic background, I'm sorry for that, is a geneticist. So I don't like this. I don't like to see 15% of the global population having an episodic disorder with no selection that makes these phenomena completely disappear in life. And geneticists have their word in this aspect because the vulnerability is around 50%, so very high. And there's one guy who wouldn't like this aspect. And this is Sir Charles Darwin, who said that the species that are going to survive are not the strongest or the smartest, but those able to adapt to the new changes. And I see depressive episodes as an incapacity to adapt to a stressful event. So why did we bring these kind of inheritage in our genome for such a long period and giving this such stable frequency of depressive episodes. So let me propose a funny explanation. You know that we are now in a very specific period, especially with a warming period, where temperature has absolutely no impact. We are completely able to cope with the variability of depression. And the point is, because of, and thanks for the medical progress, we have nearly no selection because of being more adapted now to the global climate. We completely erased this aspect of selection. But don't forget that we did that for 500,000 years. And during this period, temperature was not the same as now. And we had extremely severe glacial periods. And for these glacial periods, you needed to survive to adapt to very stressful conditions. But what was the response that was needed and was probably highly selected in order that the human species, this little human being on Earth, was able to survive? Well, the most appropriate response was depressive symptoms, because those that were able to survive for these 4 months, where you have months 30 degrees, were those able to have for 4 months, between 4 and 6, the glacial winter was very long, a very strong psychomotor retardation, very low body temperature, no appetite, a completely change of pattern of the sleep because you had to sleep most of the day, and higher inflammation process. All those aspects are biological markers of depression. So let me conclude saying that if we have to say if depressive is an episodic disorder, we might say yes, but with staging, sorry for the mistake, staging properties. Because major depressive disorder has an episodic expression, definitely based on a vulnerability which is both premorbid and acquired, leading sometimes to chronic conditions. These might have had some benefits in the past, and I like to remind that to patients. You are very lucky. It's thanks to guys like you that we survived in the winter condition, even though you might have a little bit less advantage now. And I would be interesting to know with a global warming if we're going to have another way of selection. And whatever, the main conclusion for clinicians today would be that whatever, all evidence shows that as soon as we treat very fast, we treat very on a longer aspect, just to be sure we get to complete remission. And if there is a high repetition, to treat longer to prevent recurrence, we will reduce these remaining symptoms, then reduce the stigma, and then hopefully hope the patient to get to a proper functioning, which is the aim of our clinicians. So thank you very much for your attention. And I will be, of course, happy to reply to questions.
Thank you very much, Philip. That's extremely interesting and provocative talk. I would expect nothing less from you, but I really very much like the fact that you were trying to separate out the idea that there are episodic people and there are chronic people, when it's clear from the data that you show that they move from one to the other. And I wonder whether Baldwin has some questions to ask on this issue.
Well, I would like to ask a question on the genetic aspects regarding Darwin. People in northern countries are more depressed than in southern countries. And I think maybe it's because they have to prepare for a long winter here, like 40,000 years ago, when people came to Europe, they had to prepare for the long winter. And the depressed people are better at prognosis. They say we will have a long, long winter and we will die if we don't save our food and things for animals and for ourselves. And those happy people, they just died during the winter because they were too happy. And I think also this is true for anxiety, because anxious people also think we won't survive the winter. And this is maybe why people in Norway, Finland, Sweden are more depressed and anxious than we are in Germany. And people living near the equator, they don't have to think, they only have to think from one day to the other and not wait for a long winter. What do you think about that?
Oh, sure, that's interesting. What I heard is that there is a founder effect in other countries where we know that the global Nordic population is mainly based on 5 or 6 families that arrived a couple of 100,000 years ago. And all the genetic networks are connected to these 5 or 6 initial family, the founder effect. Probably those guys might have some specificities to survive in very cold winter, as you said. So probably they do have this kind of competency to survive very difficult winter. And as I proposed, that might be relatively related to the capacity to cope with this kind of same aspect of dealing with winter, which means being depressed for half a year. And that might be maybe connected, but of course we have no proof for that.
Mm-hmm.
Yes. It is very interesting, this issue of coping, that the depressed person has to learn to cope. Indeed, when I do very long-term follow-ups of my patients that I've seen for decades, I find that some of them still have depression, but they're not prepared to talk about it. They ignore it. The best example, of course, is Winston Churchill, who talked about the black dog as something that he had from time to time, but he would ignore it by doing something which he preferred to do instead. So that the idea that the depression is part of a coping system and that depression leads to a coping system is something which your talk has brought out. I wonder if you take that further.
Yeah, sure. So that's really relates to all the avoidance behavior that we have a lot in anxiety, in fact, also in depression. And that's, of course, the worst way to cope with difficulties, because when you have a possibility to reduce the level of stress, the only way is to face the difficulty, understand the problems, and then find solution, and especially sometimes ask for support. And all of these means you have a confidence, sufficient self-esteem, and a little bit of coping strategy. All of it needs a little bit of energy and also the capacity to see that there are possible solutions. But when you are depressed, when you have a psychomotor retardation, of course, these are more difficult. And, you know, that's also for me relates a lot for these remaining symptoms. I think that for clinicians, this is for me really the most important lessons I learned from my clinical practice. All those patients that are saying, "Thank you, doctor. I feel so much better. I can sleep very well, I'm back to my work and enjoy family." And sometimes these patients have absolutely no symptoms. They are really having a complete remission. But a lot of them have some minor remaining symptoms. And for these kind of patients, I think that the CBT or mindfulness, psychotherapy is really having a very important help, which is synergic with the antidepressive treatment. And when we get to a complete full remission with all the strategies that are possible, of course, also helping them to make some choices in life as a psychiatrist, this is part of our duty, then the future is really different. We are making a very strong impact on the risk of recurrence, and then of course on the long term of chronicity. So what you are mentioning, Stuart, about this coping activity is not only a cognitive aspect, it's a strategy, it's also a symptom of depression. And if we are really focusing on this aspect and saying that you have difficulties with your coping strategies, we have to help you increasing it, because that will help you on the long term. Then we are really helping the patient to get to a better prognosis.
Yes. How are we doing for time? Is it coming close?
Yes, it's it's only 1 minute left, so we are perfectly in time.
1 minute for you to give us the final conclusion of your wonderful talk.
So the presentation was on a challenge, depression being, of course, episodic. As I said, 50% of patients have no depressive, not more than one single episode, but it's also chronic in many patients, maybe also like an evolution. So we've been proposing that it should be more an episodic with a staging aspect, maybe sometimes getting to chronicity.
Thank you very much, Philip, for that wonderful and very provocative talk. Bowen, over to you.
Okay, so I'm going to introduce the next speaker. I know him for many, many years. Stefano Palanti. He's not only expert for OCD, but also for anxiety disorders and pathological gambling, and also for ADHD. Stefano is from the University of Firenze, Florence in Italy, and also the director of the Institute for Neurosciences in Italy. And also he is always in the United States at the Mount Sinai Hospital in Stanford, USA. He is also a visiting professor at the Imperial College in London. And I don't know when you sleep, must be
a few.
Maybe in Texas, you sleep in Texas, maybe. Okay, so Stefano, please give us your talk about adult ADHD diagnosis, comorbidities, and treatment, please.
Good morning, everyone. It's my pleasure to be here today in this presentation to 2021 IFMAD, and it's really a pleasure, an annual pleasure. So my presentation will be about diagnosis, comorbidity, and treatment of ADHD in adults. Some numbers to start with. We know that the prevalence of ADHD is huge. Is in between 5 and 7% for children and adolescents, according to most recent findings. But it doesn't disappear in the adult life, and so about half or 2/3 of these patients growing up still are presenting the same symptoms of childhood with minor change. And I will try to figure what's the change, the main change, in order to be more able to recognize it in the adult life. You know that according to the DSM-5, to be diagnosed for ADHD, you have to have 5 or more symptoms of inattention, hyperactivity, impulsivity. This is the 3 cardinal point dimension of ADHD, and symptoms have to be answered before age of 12 and present in different settings, not just in school, but at home with peers, and interfere and reducing the quality of functioning of academic especially, and does not respond to any other diagnosis. So even when you find this disorder in adult, you have to look back and see if they were here just at the beginning of school or the first year of adolescence. Dimension have a different weight on the development of the disorders, because usually the dimension of inattention is related to reduced skill and executive function, slow processing, and lead to poor academic achievement. While hyperactivity instead can deal with academic, but have more drive to relational aggression, antisocial behavior, risky driving, and substance use. So different dimensions lead to different expression of the disorder in adulthood. More recently, other dimension on the top of inattention, hyperactivity, impulsivity has been described like mind wandering, that occurs when mind moves away from task and focus on internal thought and image unrelated to the activity, and so create an interference with the focus activity. And mind wandering is associated with excessive spontaneous mind wandering, because mind wandering is a part of normal mental life, but when the percentage grows, it represents an interference with your more focused activity. And it's also a cause of stress because of a continuous flow of thought, and can interfere with falling asleep and lead at the end in a deflection of mood and performance and low self-esteem. So sluggish cognitive tempo is also another way to describe this spontaneous activity that includes daydreaming, having in mind that severe slowness in movement and responding to hyperactivity. And it is estimated that these dimensions are not minor, because 1/3 or 2/3 of individuals with ADHD, especially with inattentive subtype, they have elevated level of sluggish cognitive tempo. So due to this transforming characteristic of the symptoms, adult ADHD is a challenging diagnosis, especially when it's presenting in comorbidity with other disorder that's happened quite often with adult patients, because adult patients usually if they have not been screened and treated for ADHD in childhood and adolescence, usually does not account their disorders to that origin, but they complain about the actual symptom of depression, anxiety, or they presenting for substance use disorders or other form of behavioral problem, not strictly related to inattention, hyperactivity, even if you found a subject with a prevalence of the same symptoms of ADHD transported in the adult age. One condition that has been recently considered as a part of a neurodevelopmental disorder involving ADHD is the spectrum of autism. Autism adults with autism present quite often attentional problems. Some of them are related to autism, and some other are instead related to the comorbidity with ADHD. Apparently, 40% of adults with autism spectrum have also a co-diagnosis of ADHD, and it's important because it leads to mostly inattentive behavior, and these subjects are more difficult to be engaged in any rehabilitative program. So it's important to make this diagnosis because it can lead to a better organization and better participation to rehabilitative program. In gambling disorders, there's another growing condition. We know our largest population. In Italy, we assess about 400,000 people with gambling, and it has been considered that almost 20% of gamblers have a history and presence of symptoms of ADHD. And people with gambling have 4 times more ADHD than normal average community population, and also untreated subjects with ADHD are more prone to develop substance, but also behavioral addiction. So this is something that can be considered important in order to prevent and in order to assess this interesting population. Eating disorders. We published a few years ago this paper about the dark side of eating disorder, ADHD, because girls and women with ADHD have almost 4 times greater risk of suffering of eating disorder than women without ADHD, especially in form of bulimia or binge eating. And before, ADHD could be considered as a predictor of developing eating disorders, and it is associated with the same usual component of disorder functioning characterized by impulsivity, inattention, and dysregulated eating. Beyond the psychiatric presentation, we are now publishing a few papers in other neurological or medical conditions where you can find a lot of ADHD. One of them is Parkinson. Parkinson, especially subject resistant to treatment with on-off motoric problem and usually prone to increase the dose of dopamine stimulants and characterized by dopamine dysregulation symptoms, can have also a diagnosis of ADHD. In the sample we analyzed, we found more than 1/3 of the patients with dopamine dysregulation in Parkinson have also a comorbid diagnosis of ADHD. And it's important because you cannot have a good response either of the motoric component without treating the ADHD. Of course, even in this population, when you make the assessment of being resistant, being dopamine dysregulated, motoric on-off, and attentional disorder, you have to come at the beginning back and understand if the problem starts in the childhood. One other recent finding we published on Journal of Psychiatry Research is about the presence of ADHD in adults with fibromyalgia. Fibromyalgia is a condition that is still at the center of a debate. It's true to be considered a rheumatological disease, a neurological disease, a psychiatric disease of nothing. But anyhow, there are people suffering from this painful condition, and we screen 123 subjects with fibromyalgia for ADHD, and we find out that all 4 up to 10 of the subjects have a score that suggests presence of adult ADHD. And more recently, we use the instrument for the assessment of ADHD in childhood and adolescent, and we find out that a quarter of the subjects with actual fibromyalgia have also a comorbid diagnosis of ADHD. What's the connection between pain and attention? Of course, there are several ways to explain this. First of all, pain, when it's chronic, is usually characterized by a kind of magnetic attraction of the mind to the pain. Now, subject cannot stop thinking and feeling about the pain. And also, the disharmonic functioning of tension and the absence of relaxation time in subject with ADHD can also lead to contraction and contribute to development of pain. Anyhow, there are several ways to consider it, but it's important because when we start treating this subject with the same drug for the disorder ADHD, we have an improvement of symptoms of fibromyalgia, not just of the attentional disorders. You see that ADHD itself corresponds to an increase of the disability on its own. So it's an additional pain that adds to the normal pain of fibromyalgia. And also, disability related to the pain and to brain fog, that is another of the characteristics of fibromyalgia, has also a specificity for ADHD component. Talking about pain and chronic pain, comorbidity of migraine with ADHD also has been reported in a large population of patients with migraine. So when you see a resistant patient with migraine, think about, to explore the possibility that they have also a comorbid diagnosis for ADHD. Usually migraine is associated with cognitive complaint, but also sleep disorders or some kind of reading problem, scarce motoric coordination. When you find all these aspects, please consider to make back an assessment of the neurodevelopmental history of this subject, not just because recently we have been used to assess the patient just for the history of pleasant illness, because of a time, because of a setting. Usually we see patients with pain in the emergency setting, but please go back and make a full assessment of the family history of the pregnancy or how it's been delivered and stuff in order to make a full consideration of this potential comorbidity. So this is a figure of what we call the goose game, or maybe in the English country, the snake and ladders game. That is a game where you have to go back to the start point when you find a difficulty. And this is how to process the assessment of ADHD. When you find a dimension of hyperactivity or mind wandering or impulsivity, go back to the beginning and find out if it is present from the very beginning of childhood or adolescent. How to make it? There are several instruments. I recommend everybody to use not just your clinical judgment and your clinical expertise, but to use a specific instrument for the assessment, like the DIVA-5, that is the last version of the interview for assessment of ADHD in adult by Sandra Coy and co-workers, that we translate in Italian, but there are a lot of translation in 30 different languages. And also use other instruments for the assessment of attentional functioning, because ADHD is still an attentional functioning, and some assessment have to be done with neuropsychological or even neurophysiological assessment, as much as the assessment of executive functioning, because ADHD is a disorder of executive functioning. So using DIVA that have 9 inattention criteria, 9 hyperactivity, and consider all the related disability, because it's not just the presence of the symptom, but the related disability. And also the BARS by Barclay, that is a very good instrument for the also self-report, but also clinician assessment of executive functioning in childhood as much in adult life. What to look for? Of course, neuropsychological deficits are heterogeneous because sometimes you have a deficit, a reduction of attention. Sometimes you have a sparse attention. So a subject will attend to everything that at the end they can focus. So, and it's important that not everyone can show bad result to neuropsychological assessment, but you have to observe the patient while he's doing the assessment, because you will find out a lot of information just looking to the subject doing the assessment. And you find out they might have some problem in vigilance, they might have some problem in the stop signal, and in the choice of the reaction. So I mean, it's important to make an assessment with the test, but also to observe the patient during the time of the assessment. And then treat them, even if they are adult, it doesn't mean they can respond. Even if they have not been treated for decades, they respond, and this is a recent meta-analysis about the outcome of treatment with anti-ADHD medication in adult with bipolar patient and ADHD, and you find that there is a very favorable profile. So subject even in adult life, even in comorbidity with other conditions, have to be treated. But also, when you have this diagnosis, you can use it to conform and to reshape the treatment of the primary condition accordingly. Like if you have a bipolar patient, you know that bout rate can interfere with dopaminergic function, so it's not probably the good first choice. Let's consider to use lithium that has been shown instead to improve attention. So, or if you are using quetiapine, maybe you can use another different treatment for bipolar depression, let's say another less impactful on the attentional function. So it's helpful not just to establish how to treat with appropriate anti-ADHD medication, but also to reshape the primary condition treatment. This is a recent paper that I published with my colleague Sonia Gao at Stanford, and all the dimensions of a disorder response. So there are no dimensions not responding: impulsivity, inattention, hyperactivity, but also my wandering, sluggish cognitive tempo. They respond to any of the treatment. This is not a randomized study, so you might find out that the patient with anxiety and ADHD are better suitable for treatment with atomoxetine, that methylphenidate. That is based mostly on your clinician assessment and judgment. But anyhow, the specific treatment for ADHD improve ADHD and improve the comorbid condition. And also, this is a very interesting meta-analysis of Stephen Loach that I like to present, because according to him, adults with ADHD have a greater effect size than any other treatment in terms of improving quality of life. So not only you have to treat them because they can improve, but the improvement they get is larger compared to any other condition in psychiatric adult setting. What are the effects? So they have a reduction in the use of drugs. We have patients that cannot quit assuming a drug, and instead treated with ADHD, they stop. They have an improvement in academic functioning, in occupation, interpersonal relationships. So not just to make the assessment of the clinical dimension, but also of the social interference and improvement in this population. And compared to untreated, even in comorbid condition, we have a larger number of benefit in any dimension of a life experience, but mostly in the subjective experience, because most of the subjects report a reduction of the effort of the internal activity that is consuming their energy. So they have a very large improvement of subjective experience of well-being that is extremely rewarding as a clinician. So as a conclusion, adult ADHD is a frequent presentation in clinical setting. Remember it, the larger number, 20% of bipolar, 20% of gambler have this problem. You find out probably 1 up to 10 in binge eating and bulimia, but also Parkinson and migraine and fibromyalgia and other conditions. So search for partial responders because they might have ADHD at the origins of a resistance to the treatment, and look for then for a good neurodevelopmental history with structured interview and further informative is possible, because it's important to get a very specific assessment of as part of the life. And then start with specific treatment and adapt the previous treatment accordingly. And then you will have a combination of medicine and coaching therapy that make a very rewarding for the clinician, but mostly for the patient, assessment of the improvement that involve not just subjective experience and clinical symptomatology, but also level of functioning in different dimension of the everyday life. So I wish I will convince you to consider more carefully this the presence of adult ADHD in the clinician population, and I wish that this presentation will help you a bit. Thank you very much.
Okay. Thank you very much, Stefano. Mille grazie. And I want to remind all the audience that you can ask questions to everyone, to the speaker. And please do this, because I don't see too many questions here on the screen. So I will start with a question to Stefano regarding the neurobiology of ADHD. What do you think about the reward system? Many things that people with the ADHD syndrome do have to do with the reward system, like eating disorders and also hypersexuality, gambling. All these things challenge the reward system. And so maybe we should think of treatments that target the reward system. What I do sometimes in these patients, I treat them with naltrexone, which is an opiate antagonist. So what do you think about this theory? Stefano? Oh, I think we have a problem. I say,
Stefano.
This picture is frozen.
Can you hear?
We can hear you now, but we don't see you. Okay, Stefano.
It's a period of inattention, that's all.
Yeah. Yes. Inattention period, maybe. Maybe, Stuart, we can discuss about ADHD. Yes.
Yes.
Do you have a question in the meantime?
I was very interested in the high level of comorbidity which Stefano showed. And I was wondering whether there's any evidence that treating these other comorbidities has a beneficial effect on the ADHD directly or not. I mean, all mental illness is very closely linked. High comorbidities occur in bipolar disorder, in depression, schizophrenia. Is it any higher in ADHD? What's your view, Bowen, on this?
Well, there are some treatments that do treat the comorbid condition, like methylphenidate. It also helps against drug addiction and problems in work problems and all the other comorbid conditions. Also, aggression is a problem because of the male people with ADHD. During childhood, like 50% may develop an antisocial personality disorder with which you can go to jail. And if you look in a normal jail, and you will ask all the people, the jail inmates, 50% of them have been in treatment for ADHD during childhood. This is a big problem. I see Stefano back again. Stefano,
yes,
maybe we can continue. I asked you the question about the neurobiology of ADHD. Yeah. Did you understand my question?
Yeah, I understand the question, and thank you. And I substantially agree, because there is a reward failure in ADHD. Now, because attention and reward are related. You are attentive to a thing that you feel can give you some reward. Now you learn the song you like, and you don't learn the lecture that you attend if you don't like. You know what I mean? So pleasure is a great drive for learning, and ADHD have a great problem in learning as much as a great problem in boring. They feel easily they get bored, and bored bring them to impulsive behavior. And most of the time, most of these reward failures drive them to antisocial face frustration in waiting to get things. They want to get things at once. So usually, even in the discussion, they don't have enough time, perception to deal with people. And so they became aggressive. Actually, 50% of a prisoner in the jail for especially minor have this the presence of ADHD symptoms of the illness. So I mean, of course, has to be considered, and is related to all the other drug addiction, eating disorders, and it's important to distinguish between subjects with both the two conditions, because you find much difficulty in treating an addicted patient if you don't treat also the attentional dysfunction. We see patients that have not responded to the previous treatment because the attention has not been targeted as one of the features to be corrected. And when you start to treat, now we use a lot, we have a craving target for TMS, I mean, that is becoming quite popular, cocaine. We see patients that with only TMS cannot stop, but if you treat the attention, then they have a better response. So it's extremely important.
Yes, Stuart had a question regarding comorbidity.
Yes, there's a very high comorbidity that you gave some examples of in the condition. Have you any evidence that treating the comorbidity helps the ADHD itself?
Yes, of course, there is a kind of reciprocity, because, if you treat the ADHD as a first, it depends. Sometimes you have, my experience is that, like in depression, sometimes you can treat depression first and leave the ADHD after that you have completed the treatment for depression. In OCD, is different. If you have a comorbidity for OCD, I target first the attentional problem and then the OCD problem. But also it's important because even just considering the diagnosis, even if you are not so decide to treat that, you can use it to give a special attention to the first treatment. Like I was telling, in bipolar disorders, if you start with as a mood stabilizer, you start with lithium instead of valproate. So I mean, it's important to consider in order to establish the target and also the stage of the treatment.
We have a couple of minutes left for the thing. I wonder whether you would like to summarize briefly in 1 minute, Stefano, the main message of your talk on ADHD.
The main message is that you find a lot of ADHD in the resistant population, any condition like we mentioned, bipolar, eating disorder substance, but it's a borderline personality disorders. You have to go back and assess the patient for their neurodevelopmental history. And if you find that diagnosis, even if it's a Parkinson patient,
We're losing you, Stefano. Your voice has gone into inattention mode. I think it's appropriate to thank you for very provocative talk, Stefano, and for allowing us to regard inattention as a normal phenomenon that we have. And thank you, my co-chairman, Bowen Vanderbilt, for
thank you.
his stepping in there, and to look forward to the rest of the meeting, to let you know that it starts tomorrow in the afternoon at 2:30, is it? And that I look forward to all of you coming in tomorrow to continue this discussion. Please, if you can ask more questions from the audience, it makes it much easier for us to interrogate and to understand the talk. Thank you very much indeed for your care and attention. Thank you, Borwin. Thank you, Stefano. And thank you, IFMAD.
Thank you.